All right, a very good afternoon to all of you. I am Dr. Deepthi and I'll be taking your obs and gynae sessions. We'll be starting with obstetrics today. And whenever I start with my OBGY class, there are certain rules we follow. And the simple rule is that we start from basics, right? So I'm going to really start from very, very basic things, build you up on basics, side by side tell you how the same basic can be applied into a clinical question. Also in my class, you'll be getting a lot of facts and figures and numerical values. Please be rest assured that these values are to the best of my ability, right? So you can just mug them up. Don't stick to guides. You will find different answers in various guides. They are hopeless. So please, whatever notes I'm giving you, they've been prepared with lots and lots of effort. And as I said, they are to the best of my ability. So just learn up the notes, right? You'll be getting lots of facts, figures, basics, application questions. We'll try and cover everything from the basic point only. So when we start, we'll start with, when I say basic, all right, there's another small thing that I want to add before I start. Just to keep the rhythm of the class going, I would take up whatever questions you have from your side. I will take up whatever questions you have from your side once we are finished with a particular topic. So I would start with something, a particular topic. I would cover that up and then give you a chance to ask whatever questions you want to, instead of putting up the questions in between, because that breaks the rhythm of the class. All right, so simply I would go up with a topic, explain it to you, give you whatever I want to. I will turn on the chat then so that you can ask me whatever questions you want to, right? I also encourage that whatever questions you have in between the class, it would be nice if you just keep jotting them down, and after we finish one topic, you can then come up and ask those questions. Fair enough? I think by that way, even you would be more comfortable and I will be more comfortable. We'll have the rhythm of the class and we will discuss all questions as well, right? So we start with, as I said, obstetrics. And before we actually go on to the obstetric part, what we're going to start with is anatomy. Now, I'm not going to teach you the entire anatomy. You may be better than me at that. What I am going to teach you is what I am good at. So what we are going to teach you is relevant anatomy, right? We are going to teach you relevant anatomy. In whatever new pattern questions we are getting, whether you talk about AIMS, whether you talk about PGI, or whether you talk about DNB, or for that matter, All India exam, the questions are going to be based from the basics only. So you have to have very, very clear basics, small things which are being asked, right? So therefore we start from relevant anatomy, and we also see that how the same anatomy is going to be applied in the clinical question, all right? So luckily when you talk about anatomy in OBGY, there are only few organs that we talk about. So it's uterus, cervix, vagina and ovaries majorly. And we first start with the uterus. Now, when you say the uterus is derived from what embryological structure? So the uterus is derived from the Mullerian ducts. All right, the uterus is derived from the Mullerian ducts, and the other name for the Mullerian ducts is the paramesonephric ducts. So please be very careful. Sometimes in the options, it would not be written Mullerian, which is the more commonly used term. They would write mesonephric or paramesonephric. So you should know that Mullerian ducts are also called as the paramesonephric ducts. Now, Mullerian ducts appear in the fetus at what period of gestation? At what period of gestation does the Mullerian duct appear in the fetus? It appears at 6 weeks. And when we say it appears in the fetus at 6 weeks, it means it is going to appear in both male and female fetus. So the Mullerian ducts appear in both the male and the female fetus at 6 weeks of period of gestation. And as we say that Mullerian ducts are present in the female, so it means they are going to disappear in the male fetus. The Mullerian ducts are going to disappear in the male fetus, and then again automatically there comes an MCQ where they will ask you at what period of gestation do they disappear in the male fetus. So they disappear at 8 to 9 weeks of POG. So they appear at 6 weeks and they disappear in the male fetus at 8 to 9 weeks of the period of gestation. Now since they disappear in the male fetus, anything whichever disappears always leaves behind a mark. Similarly, when the Mullerian ducts are going to disappear from the male fetus, they are going to leave behind remnants. They are going to leave behind the remnants, and the remnants of the Mullerian or the paramesonephric ducts are called as utriculus masculinus. So they are called as utriculus masculinus, and the other remnant is called as appendix of testes. So there are two remnants of the Mullerian ducts or the paramesonephric ducts in the male, and they are utriculus masculinus and the appendix of testes. The other duct which we talk about is the mesonephric duct, right? And the other name for mesonephric duct is the Wolffian duct. The mesonephric duct or the Wolffian duct, again as we said, appears in both the male and the female fetus, but the mesonephric duct or the Wolffian duct would disappear in the female fetus. So this disappears in the female fetus. Again the same rule applies. When it is going to disappear in the female fetus, it is going to leave behind remnants. So now we talk about what are the remnants of the Wolffian ducts or the mesonephric ducts. So remnants of the Wolffian ducts in the female are, number 1, the remnants of mesonephric duct, and I said also called as the Wolffian duct. In females are epophoron, parophoron, and the third is called as the Gartner's duct. Now this is an age-old question which is quite often being asked in exams. In fact, it was again asked last year in May AIMS. So remnant of the mesonephric duct or the Wolffian duct are called as epophoron, parophoron, and the Gartner's duct. Now how the same question was asked in AIMS was, what is the cranial remnant of mesonephric duct called as? So what is the cranial remnant of the mesonephric duct called as? So you should know that epophoron is the cranial remnant, whereas parophoron is the caudal remnant. So the cranial remnant is epophoron and the caudal remnant is parophoron. The epophoron has 15 to 20 tubules. The epophoron has 15 to 20 tubules. Okay, the epophoron has 15 to 20 tubules, and these tubules join to form the Gartner's duct. These tubules join to form the Gartner's duct. All the three remnants, epophoron, parophoron, and Gartner's duct, all these three remnants are contents of the broad ligament. We'll come again and explain you what broad ligament is. But as of now, what I'm saying is that epiphyron, paraphyron and Gartner's duct, they all three are contents of the broad ligament. The cranial remnant is called as epiphyron and the caudal remnant is called as paraphyron. Alright. Now the two Mullerian ducts. So there are two Mullerian ducts, one on each side, and the two Mullerian ducts have to fuse to form the uterus, right? The two Mullerian ducts have to fuse to form the uterus. So what you have to understand is that the fusion of the two Mullerian ducts, it begins in the center. The fusion of the two Mullerian ducts begins in the center and then it moves cranially and caudally. Alright, so the fusion of the two Mullerian ducts begins in the center and then moves cranially and caudally. And the uterus is formed by the fusion of the two ducts at 10 weeks. So at 10 weeks of POG, of period of gestation, at 10 weeks of period of gestation, the two Mullerian ducts have fused to form the uterus in the female fetus. So uterus would be formed at 10 weeks of period of gestation. Alright, so this is how the uterus is formed by the two Mullerian ducts. Next we talk about our certain value-based things which are asked from the same organ. So if you talk about the uterus, what is the gross shape? Gross shape means when you look at the organ, what is the shape of the organ when you look at it? So we say that the uterus is piriform in shape. The uterus is piriform in shape. There's another way how you can describe, and then they ask you the shape of the cavity. So uterus, shape of the cavity. So whenever you are asking or the question is asking the shape of the cavity, it means the shape on cut section. It means the shape on cut section. And whenever you cut an organ, you can cut it in two sections. Either we can take a coronal section or we can take a sagittal section. So when we talk about the shape of the cavity, the shape can be on a coronal section or the shape can be in a sagittal section. The shape of the cavity on coronal section is typically described as triangular. The shape of the cavity on the coronal section is described as triangular, whereas the shape of the cavity in sagittal section is described as cleft-like. So it is cleft-like in a sagittal section and it is triangular in a coronal section. Now this is a detailed answer. Sometimes the MCQ may not give you the cut section whether it is coronal or sagittal. The only thing MCQ is asking you, what is the shape of the uterine cavity? Then which is the better answer of the two? If nothing is mentioned about the type of section, then the answer remains triangular. So I'm saying if they have not specified the type of section, whether it is coronal or whether it is sagittal, the answer we stick to is triangular. And the detailed answer is that on a coronal section it is triangular and on a sagittal section it is cleft-like. Next we talk about the weight of the organ. So when you talk about the weight of the organ, we usually divide the uterus in two types, nulliparous and multiparous. Alright, so in nulliparous the weight is 50 to 70 grams. The weight of nulliparous uterus is 50 to 70 grams, whereas the weight of a multiparous uterus is 80 grams. Okay, the weight of multiparous uterus is 80 grams. Similarly, if we talk about the length of the uterus, we again will describe it in terms of nulliparous and in terms of multiparous. So the length of the uterus in nulliparous women is 6 to 8 centimeters, and the length of the uterus in multiparous women is 9 to 10 centimeters. So 6 to 8 centimeters in nulliparous and 9 to 10 centimeters in multiparous. The third thing which we talk about is volume. So what is the volume of non-pregnant uterus? What is the volume of non-pregnant uterus? The volume of non-pregnant uterus is only 10 ml. The volume of non-pregnant uterus is only 10 ml. Alright, it is only 10 ml. Now, these values which we have given you for the weight and the volume are for a non-pregnant uterus. The similar questions would be asked about a pregnant uterus. In fact, they've been asked repeatedly in various exams. So what is the weight of a term pregnant uterus? What is the weight of a term pregnant uterus? The answer is 1000 grams. The answer is 1000 grams. To be exact, the actual value is 1.1 kgs. The actual value is 1.1 kgs or 1100 grams. But whenever this question is going to come in the exams, or it has come till now, you never have 1.1 as any option. So the closest option which is always there is 1000 grams, and that is why we take it as an absolute value of 1000 grams. So this is the weight of a term pregnant uterus. A similar question which was asked this year in 2014 All India. So it is a similar question, and again quite confusing. The question said, what is the weight of uterus immediately after delivery of the baby? So what is the weight of uterus immediately after delivery of the baby? Now what some of us tend to do is we do certain mathematics in this. So we say what is the weight of the baby, so we subtract that, then we subtract the weight of the placenta, then you subtract the volume of blood. We don't have to do anything like that. These are standard questions with standard answers. So when you are asked the weight of uterus immediately after delivery of the baby, the answer still remains the same. It is 1000 grams. The answer still remains the same. It is 1000 grams. Then the third question comes as, what is the volume of a term pregnant uterus? What is the volume of a term pregnant uterus? So above this we have described the weight. Now we talk about the volume. So the volume of term pregnant uterus is 5 liters. The volume of a term pregnant uterus is 5 liters. Alright. So you can see that from a 50 gram organ, it is changing to a 1000 gram organ. So the uterus in pregnancy undergoes both. The uterus in pregnancy undergoes both hypertrophy and hyperplasia. It undergoes both hypertrophy and hyperplasia, but the hypertrophy is much more significant. The hypertrophy is much more significant as compared to hyperplasia. So if you have to select between the two options, when it says uterus in pregnancy undergoes A, hypertrophy, B, hyperplasia, then the better answer is always hypertrophy. Alright, the better answer I'm saying is always hypertrophy. Now, when you talk about the uterus, at the upper end of the uterus, on each side, 3 structures are attached. On the upper end of the uterus, on both the sides, 3 structures are attached. You are quite often required to know what are these 3 structures. So the 3 structures that are attached at the upper end of the uterus on either side are the round ligament, the fallopian tubes, and the ovarian ligament. So the 3 structures that are attached at the upper end of the uterus are the round ligament, the fallopian tube, and the ovarian ligament. Now they're not going to ask you, name the 3 structures which are attached. That is actually too simple a question, and they all think that you all know this. What they are going to ask you is the relationship between these 3 structures. So when you talk about the 3 structures, there is going to be an antero-posterior relationship. That means which structure is attached most anteriorly, which is in the middle, and which is attached most posteriorly. And the other relationship that they will ask you is supero-inferior relationship. So which structure is attached sabse upar and which is attached below, right? So first relationship that we talk about is the antero-posterior relationship, and the AP relationship is in the order which we have already written. So the AP relationship is round ligament followed by fallopian tube followed by ovarian ligament. So the most anterior structure is round ligament, in between is fallopian tube, and the most posterior structure is the ovarian ligament. So this is the antero-posterior relationship of these 3 structures. Coming to the supero-inferior relationship. Okay, now we talk about the second relationship of these structures, and it is going to be the supero-inferior relationship. So if we talk about what is the supero-inferior relation of these 3 structures, most superiorly, what is attached? The fallopian tubes. So the most superior structures are fallopian tubes. Below the fallopian tubes, the round ligament and the ovarian ligament. So below the fallopian tube, the round ligament and the ovarian ligament are attached at same level. So सबसे ऊपर fallopian tube present है, उसके नीचे same level पे आगे की तरफ round ligament है और पीछे की तरफ ovarian ligament है. So this is the supero-inferior relationship. Now you must be wondering ki why do they want you to know the supero-inferior and the AP relationship? The reason is that a lot of time when you go to the hospitals you will see कि patient की tubal ligation या sterilization procedure किया गया, but patient after 2 months comes and complains that she is pregnant. Why does this happen? It happens because a lot of people are not aware of the relationship. They do not identify the correct structure, and instead of ligating the fallopian tubes, what they do is they ligate the round ligament. So that is why the knowledge of these structures and their relationship to each other becomes very important, so that we know which structure is present where and we ligate the correct structure. Alright, so these are the structures which are attached in the upper end of the uterus. Now again we will say that all these 3 structures, that is the round ligament, the fallopian tube and the ovarian ligament, are again contents of the broad ligament. And where exactly are they present in the broad ligament? They are present at the upper end of the broad ligament. So basically, broad ligament is a fold of peritoneum. Okay? It is simply a fold of peritoneum. It has an anterior leaf and it has a posterior leaf. And in between the anterior and posterior leaf, at the top lies these three structures. That is the round ligament, the fallopian tube and the ovarian ligament. So it is like a पर्दा. एक पर्दा है, आगे भी है और पीछे भी है. आगे वाले को हम anterior leaf कहते हैं, पीछे वाले को posterior leaf कहते हैं. और in between these two leaves, what all structures are present? So we are saying in between the two leaves, so in between the two leaf of broad ligament, the structures that are present would be round ligament, the fallopian tube, the ovarian ligament. Then we also did epiphyron, we also did paraphyron, we also did the Gartner's duct. Other than this, what else is present? Blood vessels, connective tissue, nerves, ovary and its ligaments. So these are all the contents of the broad ligament: ovary and its ligaments, blood vessels, connective tissue, nerve fibers, the three structures attached at the upper end of the uterus, and the remnants of the Wolffian duct or the mesonephric duct. Alright, so these are the structures that are present in the broad ligament. Now, if you talk about the uterus and the picture that I made, alright, so this is what we made and this is where we said the three structures are attached, right? Now, often they will ask you, how do you describe the fundus of the uterus? Now, when you talk about the fundus of the uterus, or when you talk about the uterus per se, then it is divided into the following segments. There is a fundus, there is a corpus or the body, and there is a cervix. So there is a fundus, there is a corpus, there is a cervix. In between the corpus and the cervix lies the isthmus. In between the corpus and the cervix lies the isthmus. So we have fundus, then we have the corpus or the body of the uterus, then we have the isthmus, and then we have the cervix. Alright. Now we come to what I was saying was, how do you describe the fundus of the uterus? So the fundus is described as the part of uterus, the fundus is described as the part of uterus that lies above the attachment of fallopian tubes. The fundus is described as the part of uterus that lies above the attachment of the fallopian tubes. This has to be remembered as it is. It is itself as a one-liner MCQ. So the fundus is that part of the uterus that lies above the attachment of the fallopian tube. So this would be called the fundus. Alright. Just to repeat the relationship, antero-posterior, anterior most is round ligament, in between fallopian tube, and posterior most is the ovarian ligament. Superior-inferior relationship, most superiorly placed is the fallopian tube. Then both the round ligament and the ovarian ligament are attached at same level below the fallopian tube. So they are attached at the same level, but the round ligament is more anterior and the ovarian ligament is posterior. Then we come to, if you talk about the isthmus opens into the cervix. Alright, the isthmus opens into cervix, and the point where the isthmus opens into cervix is called as internal os. So internal os is the point where the isthmus opens into the cervix. And when you talk about the internal os, it is of two types. There is a histological internal os and there is an anatomical internal os. So there is a histological internal os and there is an anatomical internal os. Now they don't ask you name the two types of internal os. Again, they consider it too preliminary a question. What they would like to ask is, which of the two lies below the other? So between histological and anatomical internal os, कौन सा ज़्यादा नीचे है और कौन सा ऊपर है? So again, the relationship between the two. So the relation is that the histological internal os lies below the anatomical internal os. Okay, the histological internal os lies below the anatomical internal os. So this is the relationship between the two os. Then what we talk about after this is supports of the uterus. Now if you talk about the supports of the uterus, then you are asked to name the main supports of uterus. Alright, main supports. When you say the main supports, they are 4 in number. Alright. The first main support we can say is the uterosacral ligaments. The first main support is the uterosacral ligament. The second is called as the Macken rod ligament. The second support is called as the Macken rod ligament. The Macken rod ligament is also has 2 other names. The other names for the Macken rod ligaments are transverse cervical ligament and also called as the cardinal ligament. So the Macken rod ligament is also called as transverse cervical ligament, also called as the cardinal ligament. So one ligament and it has 3 names. So we'll not get confused in that. The third main support is the levator ani muscle. The third main support is the levator ani muscle. And the fourth main support is called as the pubocervical ligament. So there are 4 main supports of the uterus: the uterosacrals, the Macken rod or the cardinal ligaments, the levator ani muscle and the pubocervical ligament. So these are the main supports of the uterus. What you have to remember is that round ligament and broad ligament, alright, round ligament and broad ligament do not form the main supports. So the round ligament, the round and broad ligament do not form the main supports. So sometimes you can get the same question as all the following are main supports of the uterus except. So except में क्या आ जाएगा? Round ligament as well as broad ligament. They are not the main supports. The other questions which you might get from the similar part, that is the supports of the uterus, is which ligament is responsible for anteversion of uterus? Which ligament is responsible for anteversion of uterus? Alright. Now the answer to this question is round ligament. So which ligament is responsible for anteversion? The answer is round ligament. Now I'm going to write another question which is going to sound very similar. The question is, which ligament of the uterus prevents retroversion? Which ligament of the uterus prevents retroversion? Now it seems very similar to the second question, but the answer here is different. The answer to this question is uterosacral ligaments. So ligament which keeps the uterus in anteverted position is round ligament, whereas the ligament which prevents retroversion, the answer changes and it becomes uterosacral ligament. Alright. Now, sometimes you may also get a question, which is the main support? Alright. For example, if you're getting it in the All India exam, you would get it as, which of the following is the main support of the uterus? And now all options are again same. The first is uterosacral, second is cardinal, the third is levator ani, and the fourth is pubocervical. So according to this, all four should be the answer, right? Yes, so according to this, all four should be the answer. But the answer is when you have to select among these four. So if you have to select one of these four, the answer is cardinal ligament. Just like हमारे घर में जो सबसे छोटा बच्चा होता है और हमें जिससे सबसे ज़्यादा प्यार होता है, हम उसके बहुत सारे नाम रखते हैं, है ना? So sometimes somebody will call him by some pet name, the other person will call it by another pet name, because that child is most important for us. Similarly, you can remember it that because we have kept so many names of cardinal ligament, McEnroe, transverse cervical, so it is the dearest to us, or it is the most important of all the four supports. So if you have to choose between the four, the answer is going to be cardinal ligament. Now just a few minutes back, I also introduced a term to you, and the term was anteversion, right? So I just said which ligament is responsible for anteversion. So I introduced this term to you, and when we talk about this, there are two terms which we should be very clear about. So one term is anteversion. The other term is anteflexion. Anteversion and anteflexion. Now they are going to ask you, anteversion is the angle formed between which two structures? Similarly, they will ask you, anteflexion is the angle between which two structures? And we very often get confused. Majority of the times what happens in MCQs is, then out of 4 options we are easily able to rule out 2. And we usually get stuck in 2. The reason for this is our superficial knowledge. Right? So when the knowledge is superficial, हम 2 answers में अटक जाते हैं, and then we either leave it to God or we leave it to luck, or we say कि चलिए करके देख लेते हैं. So instead of leaving these small things to God, let us take them in our own hand. So a little detailed knowledge and we will be able to select between A and B. So anteversion किसके बीच में होता है? Version में क्या आ रहा है? V, है ना? Version में V आ रहा है. So we will remember that anteversion is the angle between long axis of uterus and vagina. So V आ रहा है version में, so उसमें क्या है? Vagina. So anteversion is the angle between the long axis of uterus and vagina, whereas anteflexion is the angle between the uterus and cervix. It is the angle between the uterus and the cervix which is called as anteflexion, and the angle between uterus and vagina is called as anteversion. The second thing we have to know is how much is this angle? ये कितना होता है? So angle of anteversion, that is the angle between the uterus and vagina, is 90 degrees. The angle of anteversion is 90 degrees. Whereas the angle of anteflexion, what you have to remember, is always an obtuse angle. The angle of anteflexion is always an obtuse angle, and it is variable from 120 to 170 degrees. It is variable between 120 to 170 degrees. So anteflexion is an obtuse angle of 120 to 170. Anteversion is the angle between the uterus and vagina, and it measures 90 degrees. Alright. Next we talk about is the lining epithelium of the uterus. Alright. So now when you talk about the uterus, there is a serosa. So the outermost layer is the serosa. We have myometrium and we have endometrium. So the endometrium of the uterus is lined by a single layer. It is lined by a single layer columnar epithelium. Single layer columnar epithelium, which is ciliated near the glands. So it is a single layer ciliated columnar epithelium. And where is it ciliated? It is ciliated near the glands. It is ciliated near the glands. Then if you talk about the myometrium, the uterus has three types of layers, of muscle layers. So the outer layer is longitudinal. The middle layer of the muscle fiber is crisscross. So it is arranged in a crisscross pattern. Since it is arranged in a crisscross pattern, the middle layer of the uterus is also called as a living ligature. And it forms an important question. Which layer of the uterus acts like a living ligature? It is the middle layer of the uterus. Why? What happens is there is going to be blood vessels between these fibers. When the fibers they contract, since they are crisscross, they occlude the blood vessel and prevent the development of hemorrhage. So they are therefore called as a living ligature. So the middle layer is called as the living ligature. The inner muscle layer is circular. So outer longitudinal, middle crisscross, and inner circular. What else is important? That the inner circular layer, the inner circular layer has sphincteric action. The inner circular layer of the uterus has sphincteric action. So it has a sphincter-like action at three places. The three places are uterine cornu. So there are two uterine cornus, and the third place at which it has a sphincteric action is the internal os. So at two uterine cornues and at the level of internal os, the inner circular muscle fibers have a sphincteric action. Now you must be wondering what cornu is. So what is cornu? Cornu is the opening of the fallopian tube. The cornu is the opening of the fallopian tube in the uterine cavity. So this is nothing but it represents the intramural part of the fallopian tube. So I'll explain it again when we come to fallopian tube as the structure. But the cornu is the opening of the fallopian tube in the uterine cavity, and it is nothing but the intramural part of the fallopian tube. It is intramural part of the fallopian tube. So why I am laying so much importance on it? Because this came this year, not this year, but in November AIMS as an MCQ, right? So they asked which part of the fallopian tube behaves like an anatomical sphincter, and the answer is the intramural part. So which part behaves like an anatomical sphincter? It is the intramural part, and the reason is because the circular muscle fibers are arranged here as a sphincteric action or in the form of a sphincter. Alright, next we talk about is, since we are talking about the endometrium, you are also asked about the thickness of the endometrium. So we are asked the thickness of the endometrium during different phases of the menstrual cycle, right? So if you ask about endometrium, what is the thickness on day 5 of the menstrual cycle or immediately post menstruation? So what is the thickness of the endometrium immediately post menstruation? The answer is 0.5 mm. The thickness of the endometrium immediately post menstruation is 0.5 mm. What is the thickness in pre-ovulatory phase? In pre-ovulatory phase, the thickness is around 3 mm, and in the luteal phase, it is around 5 to 6 mm. Now please understand that this is the minimum thickness that will be present. Maximum may vary from person to person because it is physiological, it will vary, but this is what it should be, to the minimum in these 3 phases of the menstrual cycle. So on day 5 it should be 0.5 mm, pre-ovulatory 3 mm, and luteal phase is 5 to 6 mm. Now when you talk about the endometrium has a superficial layer and it also has a basal layer. So there is a basal endometrium and there is a superficial endometrium. So what we must know is that during menstruation, only the superficial layer is shed off. Only the superficial layer of the endometrium is shed off. The basal layer never is shed off. In fact, the basal layer helps in regeneration of the endometrium. The basal layer helps in regeneration of the endometrium. Alright, so this was about the uterus, but the uterus is incomplete without the cervix. So we said that the isthmus opens into the cervix via the internal os. So now what we are going to talk about is cervix. Now the first thing when you talk about the cervix, the first questions which come to our mind is ratio of cervix to corpus. So the ratio of the cervix to the body of the uterus in different phases of a woman's life. So what is this ratio at birth? What is this ratio before puberty? What is the ratio after puberty? What is the ratio in reproductive life, and what is the ratio at menopause? So the ratio is going to change throughout the woman's life. So once you talk about cervix to corpus at birth, it is 1:1. At birth, it is 1:1. Before puberty, it is 2:1. After puberty, it becomes 1:2. After puberty, it is 1:2. In reproductive life, it will be 1:3. And at menopause, again, it is 1:1. So at birth, 1:1. Before puberty, 2:1. After puberty, 1:2. Reproductive life, 1:3. And menopause, 1:1. Now, having given this to you, if you get it in the exams, at this point, I will say 50% of you will still mark wrong answer. ठीक है, 50% आप में से अभी भी सेम सवाल का जवाब गलत देंगे. क्यों, ऐसा क्यों है? Because whenever you come across a question which is as it is from your notes, you get super excited and you don't read the question carefully. So what that question would be asking you is corpus to cervix. But you don't pay attention to that. Once it says corpus to cervix, these ratios would simply reverse. So please be very attentive when you're reading the question, whether it is asking you cervix to corpus or whether it is asking you corpus to cervix. Alright? And we should not make those silly mistakes just because we did not read the question properly. Alright? So we are talking about cervix, and we said the first and foremost thing is that the ratios of cervix to corpus in different phases of reproductive life. What we talk about next is the shape of the cervix. Now, if you talk about the shape of cervix, that is the gross shape of the organ, it is described as conical. The gross shape of the organ is described as conical. But again, they will ask you the shape of canal. What is the shape of the canal? So cervix is a canal, right? There is a cervical canal, or it is a hollow organ. So what is the shape of the canal? Now the shape of the canal is best described as fusiform. It is best described as fusiform. But many books also describe it by another term called as spindle shaped. So we can say the canal is either fusiform or it is spindle shaped. Now please understand, in some of your guidebooks they have written the shape of the canal in nulliparous and the shape of the canal in multiparous. There is no such division of shape of the canal into nulliparous and multiparous. We simply describe the shape of the canal as fusiform or spindle shaped. Alright. The next you should know is external os. So हमने देखा था कि isthmus is opening into the cervix via internal os, and then the cervix opens into the vagina via the external os. So once you talk about the external os, again they ask you the shape. The shape of the os is definitely divided in nulliparous and in multiparous. So it is not the canal which we divide, it is the shape of the external os which we divide. And the shape of the external os in nulliparous is described as circular, and the shape of the os in multiparous is described as a transverse slit. So it is described as a transverse slit in multiparous and circular in nulliparous. Now same cheez ko we can ask you in another form as it came this year in the exam. So they did not write the term multiparous. The question asked was, what is the shape of external os after delivery of the baby? And it means the same thing. So the answer will remain as transverse slit. So whether they write it as multiparous or what is the shape after delivery of the baby? The answer is a transverse slit. Okay, the answer is a transverse slit. Now, if you still go on and talk about cervix, cervix has a special feature. Cervix is mainly made up of connective tissue. ज़्यादा किस चीज़ से बना है cervix? Connective tissue से बना है. And it has plenty of glands. So उसमें बहुत सारे glands हैं, बहुत सारा connective tissue है, but it has very little muscle fiber. So, unlike the other organs, the muscle tissue constitutes the least amount in cervix, and it is mainly made up of glands and connective tissue. Feature about the glands, when you talk about the glands of the cervix, are that the glands are branching. So they are branching glands, and that is why on histopathology we give a characteristic name to the appearance, and it is called as arbor vitae. So the characteristic name we give to these branching glands on histopathology is called as arbor vitae. So arbor vitae kahan ka feature hai? Cervix ka. It is used to describe the cervix. Alright. Now this is about the gross anatomy of uterus. Per se we are saying uterus and cervix. Now anatomy is really incomplete if you don't talk about the blood supply, the nerve supply, and the lymphatic drainage. Alright, so that becomes very, very important because that forms the applied part of the questions. Now, when you talk about the uterus, what is the blood supply of the uterus by? The blood supply to uterus is by which artery? It is, luckily we have a artery by the name of the organ, so it's really easy to remember, and the answer is uterine artery. ठीक है, so the artery which supplies is the uterine artery. क्योंकि ये बहुत सिंपल है इसलिए ये चीज़ नहीं पूछी जाएगी. यूट्रस कौन सी आर्टरी से सप्लाई लेता है? यूट्राइन आर्टरी से. बट देर आर प्लेंटी ऑफ अदर क्वेश्चंस व्हिच शुड बी आस्क्ड एट दिस फ्रॉम द सेम कॉन्सेप्ट. नाउ व्हाट यू शुड नो इज यूट्राइन आर्टरी इज अ ब्रांच ऑफ विच आर्टरी? So uterine artery is a branch of, I know all of you must be saying, internal iliac. Yes, it is a branch of internal iliac artery. But as I said, the examiners tend to act smarter than us. So option A would be anterior division of internal iliac and option B will be posterior division of the internal iliac. So now which one are you going to mark? The answer or the complete answer is anterior division of the internal iliac artery. So uterine artery is a branch of anterior division of the internal iliac artery. Accompanied by the uterine artery, there is a uterine vein. So uterine artery is going to be accompanied by the uterine vein. Now when you talk about uterine artery, other than the fact कि ये किसका branch है, there is another one relationship which is important with respect to the uterine artery. So uterine artery का course कैसे होता है? वो ऐसे internal iliac से आती है. There is a horizontal path. It reaches the uterus and then it ascends upwards and gives branches to the uterus. Okay, this is how the uterine artery is going. Now, during its horizontal course, the uterine artery runs over or above the ureter. So this is the ureter and this is the uterine artery. Knowing this relationship is very, very important to an obstetrician or to a gynecologist. If I am not aware of this relationship, that at this place the uterine artery and the ureter are very close to each other, if I don't know it, what will I do? If I am going to ligate the uterine artery, I will ligate the ureter as well with it. So I will cut the ureter along with the uterine artery if I am not aware of this relationship. Therefore, what will happen? If I cut it, what will I see? Suddenly I will see water in my operative field, which is not actually water, it is urine. So this is therefore called as water under the bridge. So this area where the uterine artery crosses over the ureter is called as the water under the bridge. It is also important because this is the most common site of ureteric injury. This is the most common site of ureteric injury. Alright. Another MCQ would be, or which the way it has come this year in AIPG, what is this distance where the uterine artery crosses the ureter? So this is 2 centimeters lateral to the cervix. So where is uterine artery crossing the ureter? 2 centimeters lateral to the cervix at the level of internal os. Or it is 1.5 centimeters lateral to the fornix. So it is 2 centimeters from the cervix or 1.5 centimeters from the fornix. So 1.5 centimeters lateral to the fornix, again at the level of internal os. So this is the most common site of ureteric injury, irrespective whether we are talking about obstetric surgeries or gynecological surgeries. The most common site of ureteric injury is where it is crossed by the uterine artery. It comes as an MCQ again and again. So the most common site of ureteric injury is where it is crossed by the uterine artery. I'm saying irrespective of whether it is an obstetric surgery or a gynecological surgery, the most common site remains this. It is also called as water under the bridge and it lies 2 centimeters lateral to the cervix. Once I say the most common site, you should also know what is the second most common site of ureteric injury. What is the second most common site of ureteric injury? And the second most common site is at the pelvic brim. So the second most common site of ureteric injury is at the level of pelvic brim. Okay, it is at the level of pelvic brim. Once we have talked about the uterine artery, once it comes in contact with the uterus, gives certain branches. Quite a lot of times you are asked, you are aware of the names, some is called an arcuate artery, some is called as radial. So आप लोगों को कैसे confuse करते हैं MCQ में? They will ask radial arcuate की branch है या arcuate radial की branch है? Spiral radial की branch है या spiral arcuate की branch है? So we again lose it and you tend to mark whatever is the answer, but we should not make it like that. If you talk about the branch and the order in which they are given off, so I usually make a mnemonic. Now I say that for you, and if you wish you can say that for me. So I say you are the best. So that's the mnemonic. I say that for you, you are the best. So U stands for uterine artery. So सबसे पहले है uterine artery. It gives off the arcuate artery. The arcuate artery in turn gives off the radial artery. And the radial artery gives off both. The radial artery gives off both the basal artery and the spiral artery. The basal artery supplies the basal endometrium. The spiral artery supplies the superficial endometrium. The radial artery supplies the majority of myometrium. The arcuate artery supplies also the myometrium, right? So majorly the myometrium is by the radial. The superficial is also by the arcuate. So this is the order. So the uterine artery gives off the arcuate, which gives off radial, and the radial gives off basal and the spiral arteries. Alright. Now we come to nerve supply. जब भी यूट्रस कॉन्ट्रैक्ट होता है तो पेशेंट को बहुत पेन परसीव होता है ना? Those contractions are very very painful. So this is what they ask you. What nerve fibers carry the pain sensations? What nerve fibers carry the pain sensations during uterine contractions? So simply, what nerve fibers carry the pain sensations from the uterus? And the answer is T11, T12. Okay, the answer is T11, T12. ये एक सिंपल डायरेक्ट MCQ है. इसी चीज को अप्लाइड तरीके से कैसे कैसे पूछ रहे हैं आजकल. सो अब पूछेंगे कि मुझे एक पेशेंट का सिजेरियन सेक्शन करना है. ठीक है, मुझे एक पेशेंट का सिजेरियन सेक्शन करना है, तो कौन से लेवल पे ब्लॉक देंगे? अगर एक मुझे पेशेंट का सिजेरियन सेक्शन करना है तो कौन से लेवल पे ब्लॉक देंगे? सो यूट्राइन कॉन्ट्रैक्शन से पेन कौन सा कैरी कर रहा है? T11, T12. सो ऑटोमेटिकली आप लोगों को लगता है कि इसके ऊपर अगर हम ब्लॉक दे देंगे तो पेन खत्म हो जाएगा, एंड दैट शुड बी द आंसर. एंड लॉट ऑफ यू, इनफैक्ट जब एम्स में ये क्वेश्चन आया था तो आंसर बहुत सारे लोगों ने T10 मार्क किया था, विच इज रॉन्ग आंसर. ठीक है, इट इज द wrong answer. The level of block for a cesarean section is T4. The level of block for cesarean section is T4. Now what is the logic behind it? The logic is कि जब हम cesarean section करते हैं, we also give incision on the peritoneum, and there is a lot of stretching and pulling of the peritoneum that the obstetricians do. So you have to conk off the nerve supply to the peritoneum as well. Otherwise patient cesarean नहीं करने देगी. ठीक है, तो peritoneal की nerve supply को भी बंद करना होता है. Therefore the level of block for cesarean section is T4. ठीक, एक और तरह से देखें, अगर यही चीज क्लिनिकली हमसे पूछी जाए कि मुझे एक पेशेंट का वेजाइनल डिलीवरी में, मुझे एक पेशेंट की वेजाइनल डिलीवरी करनी है और उसके लिए मैं उसे एनाल्जेसिया देना चाहती हूँ, विच इज ऑल्सो डिस्क्राइब्ड एज पेनलेस लेबर. ठीक है, एंड हाउ डू वी गिव दिस एनाल्जेसिया? वी गिव इट इन द एपिड्यूरल फॉर्म. सो व्हाट यू गिव इज एन एपिड्यूरल एनाल्जेसिया. नाउ व्हेन यू आर गिविंग इट फॉर वेजाइनल डिलीवरी, then the level of block would be T10, because now we are not doing anything to the peritoneum. We just want that the pain sensation is not carried from the uterus, and the answer would remain as T10. Similarly, another third way in which the same question can be asked. I am going to apply forceps in my patient. Okay? I am going to apply forceps in my patient, and if I'm going to apply forceps, the patient is very apprehensive and she wants analgesia. Now, what should be the level of analgesia? So, again, since forceps is nothing but an operative vaginal delivery, since it is an operative vaginal delivery, again we will say that the level of block should be T10. So, whenever you are conducting a vaginal delivery and you want analgesia, the level would be T10. But if I am doing a cesarean section, then if I want to put the block, then the answer has to be T4, because we have to conk off the peritoneum of its nerve supply. Alright? Now, usually for forceps, we don't give these blocks. What we give for a forceps, this was just an example that in case they ask you like that, but when you talk about forceps, what we give is a pudendal nerve block. Alright, so what we give for forceps is a pudendal nerve block. Now when I say that, whatever I say, I am saying in class because there is some relevant question related to it. The question related to this is, which ligament is pierced? Which ligament is pierced when you are giving a pudendal nerve block? And the answer is sacrospinous ligament. So the ligament which we pierce to give the pudendal nerve block is the sacrospinous ligament, alright? And why? Because the pudendal nerve is present in the pudendal canal which lies just behind the sacrospinous ligament. So we pierce the ligament and we would reach the pudendal nerve and we anesthetize the nerve there. Okay? Talking about the lymphatic drainage of the uterus. The lymphatic drainage of the uterus is mainly to the internal iliac group of lymph nodes. It is mainly to the internal iliac group of lymph nodes. Some also goes to external iliac group of lymph nodes. So it goes to internal iliac, it goes to external iliac. What they would ask you is, fundus of uterus, where does it drain? Where does the fundus of the uterus drain into? So the fundus of uterus drains into para-aortic lymph nodes. The fundus of the uterus drains into the para-aortic lymph nodes. Since it is different from the rest, it is often asked in the exams, it drains into the para-aortic lymph nodes. If you talk about the cervix, if we talk about the cervix, then the sensory fibers from cervix, travel via which nerves? S2, 3 and 4. The sensory fibers from the cervix travel via the S2, 3 and 4 nerve segments. The blood supply to the cervix, is via the descending cervical arteries. The blood supply is via the descending cervical arteries. Now they are going to ask you, the descending cervical artery is a branch of which artery? Then the descending cervical artery is a branch of uterine artery. It is a branch of the uterine artery. Another related thing which we should know is what is the location of these descending cervical arteries. So if we make the cervix in the form of a circle, then we say that the descending, or the clock positions, then we say that the descending cervical arteries are present at 3 o'clock position and at 9 o'clock position. So the descending cervical arteries are present at 3 o'clock and 9 o'clock positions on the cervix. Now why is it important to know where are the descending cervical arteries? A lot of times in obstetrics at various places, you must have heard about a paracervical block. Yes? We very often say that we are going to give a paracervical block for every procedure. Now when you say a paracervical block, that means you are going to put the anesthetic agent into the cervix. So where do we put it? This is the importance why you should know that the descending cervical arteries are present at 3 o'clock and 9 o'clock. Since the arteries are present at these levels, we don't give the block at this level because we don't ever give blocks intra-arterial. So we would either give a block one level above, which is 2 o'clock and 10 o'clock. So either we give it one level above on either side or one level below on either side. So either we give the block at 2 and 10 or we give the block at 4 and 8. But we never give the block at 3 and 9 because of the presence of descending cervical arteries at that level. Okay? Because of the presence of descending cervical artery at that level. The next structure we talk about is the fallopian tubes. Now when you talk about the fallopian tubes, again, they are derived from which embryological structure? So the fallopian tubes are also derived from the Mullerian ducts. They are also derived from the Mullerian ducts, also called as the paramesonephric ducts. The fallopian tubes are about 10 centimeters long. The fallopian tubes are about 10 centimeters long. If you talk the parts of the fallopian tube from medial to lateral, so when you say medial, you mean the one which is closest to the uterus, and lateral would mean the one which is most farther away from the uterus. So when we talk from medial to lateral, the parts are called as interstitial part, also called as the intramural part. So interstitial or intramural. Then comes the isthmus. Then comes the ampulla, and finally the infundibulum or the fimbrial part. So infundibulum or the fimbrial part. Now there are a couple of questions which come from this. First, we should know which is the, or first let us talk about the length of these parts. So out of these, the ampulla is 5 centimeters long. The ampulla is 5 centimeters long. Isthmus is about 3 centimeters long. And the interstitial part is about 2 centimeter. Most of the books give it in the form of 1 to 2 centimeter long. So ampulla 5 centimeter long, isthmus 3 centimeter long, and interstitial part or intramural part is 2 centimeters long. More important than the length is the diameter. So you are asked which part is the narrowest and which part is the widest. So ampulla is the widest part. It has a diameter of 6 mm. So it is the widest part of the fallopian tube is the ampullary part, and the narrowest part is the interstitial or the intramural. A lot of your guides give the answer as isthmus, and that's the wrong answer. Isthmus is not the narrowest part. The narrowest part of the fallopian tube is interstitial or intramural. So the diameter of the isthmus is 1 mm, and whereas that of the interstitial or the intramural part is 0.7 mm. So the narrowest part of the fallopian tube is the interstitial or the intramural. Also, when you talk about the fallopian tube, what is the lining epithelium of the fallopian tube? What is the lining epithelium of the fallopian tube? So again, when we say fallopian tube and its lining epithelium, it is described as single layer ciliated columnar. Okay, so it is described as single layer ciliated columnar. Types of cells found in the fallopian tube. So the fallopian tubes have 3 types of cells. It has ciliated cells, it has secretory cells, and the third type of cells, which often are asked again in exams, are called as PEG cells. So there are 3 types of cells which are present in the fallopian tubes: ciliated, secretory, and PEG cells. You have questions related to each of these. Now, what is the indirect question that you should know about the ciliated cells? Now, they will ask you what is responsible or what is mainly responsible for movement of conceptus. What is mainly responsible for the movement of conceptus towards the uterine cavity? Now, the answer to this question is not the ciliary movement. Alright? So, the main action which is responsible for the movement of the conceptus towards the uterine cavity is the muscle contractions. So, the muscles of the fallopian tube undergo contractions, which is responsible or primarily responsible for the movement of the conceptus towards the uterine cavity, and it is not the cilia. Cilia do play a role in this movement, but they are not the major contributors. The major contribution is by the muscular activity of the fallopian tube. What about secretory cells? They ask you an indirect question. The indirect question is, early conceptus derives its nutrition from. Early conceptus derives its nutrition from. Now, whenever we talk about nutrition, obviously the options are going to be in the form of glucose, glycogen, fructose, pyruvate, and stuff like that. And the moment we talk about nutrition, most of you want to answer it as glucose or glycogen. Now, the answer to this question is pyruvate. This is because the secretions of fallopian tube, or the secretory cells of the fallopian tube, or the secretions are rich in pyruvate. They do not secrete glycogen, they secrete pyruvate. And the early conceptus, by which we mean when the conceptus lies in the fallopian tube, where is it going to take its nutrition from? And the answer is pyruvate. Alright. Third, we talk about the PEG cells. As far as the PEG cells are concerned, they are called as the resting cells of the fallopian tube. Their exact function is not known. Maybe they take over the function of other cells later, but they are called as the resting cells. You get the question as, resting PEG cells are characteristic to which organ? Again, your guides give the answers as vagina, and it is the wrong answer. PEG cells are not seen in the vagina, they are seen in the fallopian tubes. Alright? Okay, so when we talk about the fallopian tubes, we've talked about the basic architecture, and then we come to the blood supply. So we say that the fallopian tubes have a dual blood supply. They have a dual blood supply. The medial half of the fallopian tube derives its blood supply from the uterine artery. The medial half derives its nutrition from the uterine artery, whereas the lateral half derives its nutrition from, blood supply from the ovarian artery. So medial half from the uterine artery, and the lateral half derives its blood supply from the ovarian artery. Right? Coming to the nerve fibers which carry the sensations from the fallopian tube. So if you talk about the nerve fibers which carry the sensations from the fallopian tube, so sensory fibers from FT, or from the fallopian tubes, travel via T11, T12 and L1. So they travel via T11, T12 and L1. Talking about lymphatic drainage, major lymphatic drainage of the fallopian tube, major or mainly, however you want to describe it as. So the major lymphatic drainage of the fallopian tube goes to the para-aortic lymph nodes. It goes to the para-aortic lymph nodes, whereas some lymphatic drainage also goes to superficial inguinal lymph nodes. Some also goes to superficial inguinal lymph nodes. But if it comes as a question, the answer you're going to mark is if you have to select, then I said majorly it is the para-aortic lymph nodes. Right? Majorly it is going to be the para-aortic lymph nodes. Next structure we talk about is the vagina. And whenever we talk about the vagina or any anatomical structure, the primary thing is from where is it embryologically derived? Right? From where is it embryologically derived? And we again say that it has a dual origin. So vagina has a dual origin. Okay, we divide it into upper 2/3 and the lower 1/3. We say that the upper 2/3 of vagina is derived from the Mullerian ducts. The upper 2/3 of vagina is derived from the Mullerian ducts, also called as the paramesonephric ducts, whereas the lower 1/3 is derived from the urogenital sinus. The lower 1/3 is derived from the urogenital sinus. Now, the same thing has been asked in different forms. They will also ask you the germ layer from which these two things are relatively, or from which they are derived. So, if you talk about the upper 2/3, it is derived from the mesoderm. The upper 2/3 is derived from the mesoderm of the Mullerian ducts, whereas the lower 1/3 is derived from endoderm of urogenital sinus. So upper 2/3 is derived from the mesoderm of Mullerian ducts, whereas the lower 1/3 is derived from the endoderm of urogenital sinus. So this is about the embryological development of vagina. We say that the vagina is 7 to 10 centimeters long. It has 4 walls. There is going to be an anterior wall, a posterior wall, and 2 lateral walls. Right? Now, the applied question that they ask you is, which wall is longer than the other and by how much? Okay, I'm repeating it. Which wall is longer than the other wall and by how much? So we say that the posterior wall is longer than the anterior. So we say that the posterior wall is longer than the anterior wall by 2 centimeters. Posterior wall is longer than anterior wall by 2 centimeters. Again, something very important about the vagina is that the vagina lacks glands. Okay? The vagina lacks glands. It has no glands of its own. So whatever secretions are present in the vagina, are derived from the cervix. So they are cervical secretions, or they are from the Bartholin's gland. So the secretions in the vagina come either from the cervical glands or they come from the Bartholin's gland. When you talk about the cervical secretions, there is an important question which is about the pH of these secretions. So the pH of vaginal secretions, throughout the menstrual cycle, except during menstruation. So except during menstruation, the pH throughout the menstrual cycle is maintained acidic. It is between, or rather we should give you the newer values, between 4 to 4.5. So the pH of vaginal secretions throughout the menstrual cycle is between 4 to 4.5. I said except during menstruation. So what is the pH during menstruation? During menstruation it becomes alkaline. It is 6.5 to 7.5. During menstruation it is alkaline that is 6.5 to 7.5. Even at menopause, it is 6.5 to 7.5. Even at menopause, it is 6.5 to 7.5. During pregnancy, it is again acidic between 4 to 4.5. During pregnancy, it is again acidic between 4 to 4.5. Now, why is this acidic? Because the secretions are acted upon by which bacilli? The Dodderlein's bacilli, which converts the glycogen into acid. The Dodderlein's bacilli, which are physiologically present in the vagina, maintain the vaginal pH as acidic, and this is in order to protect it from the infections. But when you talk about the Bartholin's gland, there is something characteristic to its secretions. The Bartholin's gland are going to secrete into the vagina during coitus, so they don't secrete otherwise. The secretions from the Bartholin's gland into the vagina come during coitus, and these secretions are alkaline. So in fact, that's a very important role played by the Bartholin's gland, because had this pH not been alkaline, the sperms would never be able to survive in the vagina, because acidic pH is detrimental to the sperms. So the Bartholin's gland are produce their secretions during coitus. They produce alkaline secretions so that the sperms are able to survive in the vagina. Okay? So that the sperms are able to survive in the vagina. That is the role of the Bartholin's gland. We'll talk more about it a little while from now, but as of now we come to the blood supply of vagina. Whenever you talk about the blood supply or you talk about the lymphatic drainage of vagina, we divide it into three parts. We say there is an upper 1/3, there is a middle third, and there is a lower 1/3. The upper 1/3 of vagina is supplied by the uterine artery. The uterine artery gives the descending vaginal arteries. So it gives the descending vaginal branches. To the upper 1/3 of vagina. The middle 1/3 are supplied by the inferior vesical artery. The middle 1/3 is supplied by the inferior vesical artery, and the lower 1/3 is supplied by the middle rectal. It is supplied by the middle rectal and the internal pudendal artery. So the lower 1/3 by the middle rectal and the internal pudendal, the middle by the inferior vesical, and the upper 1/3 by the uterine. Talking about lymphatic drainage, again we say we will divide it into upper, middle and lower thirds. The upper 1/3 drains into the external iliac group of lymph nodes. Alright, so the upper 1/3 drains into the external iliac. The middle 1/3 drains into internal iliac, and the lower 1/3 drains into the superficial inguinal lymph nodes. It drains into the superficial inguinal lymph nodes. So this is about the lymphatic drainage of the vagina. Then what is the lining epithelium? The lining epithelium of the vagina is stratified, squamous, non-keratinized. So it is stratified squamous epithelium and it is non-keratinized. So stratified squamous and non-keratinized is the lining epithelium of the vagina. Now, we then talk about a little about the external genitalia and the relevant questions we get from it. So when you talk about the external genitalia, the kind of questions we're asked are about the homologous organs between the male and the female, and from what structures are they embryologically derived. So whenever you talk about the external genitalia, there is a genital tubercle, there is a genital fold, and there is a genital swelling. So genital tubercle, genital fold, and genital swelling. The genital tubercle gives rise to clitoris in the females and it gives rise to the penis in the males. So tubercle gives rise to clitoris in the females and the penis in the males. The genital fold gives rise to labia minora, and the homologous structure in the males are penile urethra. So labia minora and penile urethra. The genital swelling forms the labia majora, and the homologous structure in the males is the scrotum. So these are the homologous structures and their derivatives. Now, what is the homologous structure of Bartholin's gland in the males? So what is the homologous structure to Bartholin's gland in the males? These are called as Cowper's glands, also called as bulbourethral glands. So the homologous structure to the Bartholin's gland are the Cowper's glands or the bulbourethral glands, right? What is the homologous structure to the prostate? The homologous structure to the prostate are the peri and paraurethral glands of Skene. Peri and paraurethral glands of Skene. Alright. Also, they're very fond of asking the lymphatic drainage because there is a small catch there. And until and unless you know that that is the catch, you would most of the times mark it wrong, or you would not know when somebody is answering this or when are you changing the answer to the other. For example, what I'm trying to say is they will ask you, what is the lymphatic drainage of clitoris? Right? What is the lymphatic drainage of clitoris? So if it is asked just like this, what is the lymphatic drainage of clitoris? Then the answer is superficial inguinal lymph nodes. So if they ask you only this much, lymphatic drainage of clitoris, the answer is superficial inguinal lymph nodes. On the other hand, I am just going to add a word to it. The word in front is going to be glans clitoris. So you will have a similar question asking you, what is the lymphatic drainage of the glans clitoris? So majority of you, what you do is you completely, have a blinding to the word glans. You read clitoris and you mark superficial inguinal. Whereas if we add glans word to it, the answer changes to deep inguinal lymph nodes, which are also called as lymph nodes of Cloquet. So the glans of the clitoris drains into the deep inguinal lymph nodes, whereas the clitoris itself drains into the superficial inguinal. क्लाइटोरिस के साथ हम we will add labia majora. So clitoris and labia majora drain into superficial inguinal lymph node, whereas the glans clitoris and labia minora drain into the deep inguinal lymph nodes, also called as the lymph nodes of Cloquet. Alright. Next we talk about is a few more things about the Bartholin's gland, because they are quite often asked. So till now what we read about this was that the Bartholin's gland is homologous to the Cowper's glands. It secretes at the time of coitus. The secretions are alkaline. Alright, the secretions are alkaline. And next what we should know is that in the females, the Bartholin's gland, the Bartholin's gland are a content of superficial perineal pouch. They are a content of superficial perineal pouch, whereas their homologous organs, the Cowper's glands, in the males, the Cowper's glands are a content of the deep perineal pouch. They are a content of the deep perineal pouch, whereas the Bartholin's gland are a content of the superficial perineal pouch. Also, when you talk about the Bartholin's gland, there is a gland and there is a duct. So Bartholin's has a gland and it has a duct. The lining epithelium of the gland is columnar. The lining epithelium of the gland is columnar, whereas the lining epithelium of the duct is transitional. The lining epithelium of the duct is transitional, whereas that of the gland is columnar. Right? Now, Bartholin's gland is of special importance to us because it is notorious to form cyst and abscess. So Bartholin's gland will form cyst and abscesses. Now, once you talk about cyst and there is formation of a recurrent cyst, the treatment of a Bartholin's gland cyst or a recurrent cyst is called as marsupialization. The treatment of the Bartholin's gland cyst is marsupialization, whereas the treatment of the abscess of Bartholin's gland is incision and drainage. The treatment of the abscess of Bartholin's gland is an incision and drainage, but that's not the complete answer. The complete answer is incision and drainage and putting a word catheter. So what we are going to do is, for the abscess, we are going to do incision and drainage, and we are going to put a word catheter inside so that the abscess does not get reformed. So for the cyst of Bartholin's gland, the treatment is marsupialization, whereas for the abscess, it is going to be IND. Another thing which you should know is that where do the ducts open? Where does the duct of Bartholin's gland open into? So when you talked about the duct of the Bartholin's gland, it opens at the junction of the duct of the Bartholin's gland opens at the junction of anterior 2/3 and posterior 1/3. So the duct of the Bartholin gland opens at the junction of anterior 1/3 and anterior 2/3 and posterior 1/3 in the groove between labia majora and minora. So where does the duct of Bartholin gland open? It opens at the junction of anterior 2/3 and posterior 1/3, anterior 2/3 and posterior 1/3 in the groove between labia majora and labia minora. This is where the duct opens. Also, sometimes it will not be given in the form of junction of anterior 2/3 and posterior 1/3. It will be given in the form of positions of the clock. So how do we describe it in positions of the clock? So if we say junction of anterior 2/3 and posterior 1/3, this is described as nothing but 5 and 7 o'clock position. So we say the ducts of the Bartholin's gland open at 5 o'clock and 7 o'clock position in the groove between labia minora and majora. So they open at 5 o'clock and 7 o'clock position in the groove between labia majora and labia minora. Alright? So with this we finish the relevant anatomy part. I've deliberately left ovary from this because ovary we're going to cover in the next section, and the next section we're going to take up is going to be relevant embryology. Alright, so now what we're going to deal with is embryology. And when we say again embryology, it is going to be a relevant embryology. Now some of you are wanting break. How many of you want a break? Do you want a lunch break right now? Alright. So what we can do is, it is 3:05 by my watch. A tea break. Okay, so it's not a lunch break, it's a tea break. We'll come to the detailed discussion about the lymphatic drainage of cervix when we come to CA cervix, don't worry. Alright? I'm not going to take up the CA cervix part here. We're going to deal with it when we come to that topic. Don't worry, you'll get the answers of every question that you have a doubt in. Alright, so we take a 15-minute break. It's 3:05 and we start the class at 3:25. Alright? Alright, so we take a 15-minute break and we start the class at 3:25. Right? Yes, I'm going to take up ovary after the break section. I'm going to include it in embryology. So I've left it on purpose. The ovary is going to be taken up with the embryology section. Alright? Alright, so we start back, and as I said, after anatomy we're going to take up embryology. And what again we're going to take up? Like now there's nothing. I said if it's a Bartholin's abscess, it has to be an IUD. Alright, it has to be an incision and drainage, along with putting a word catheter. Alright, that is what I said. Right, so I said if it is an incision, if it's a Bartholin's abscess, an incision and drainage has to be done, and we put a word catheter with it. Alright, so now we start with embryology, and again what we're going to talk about is only relevant embryology. Now when we start with relevant embryology, we are first going to deal with the gonads. So, from where are the testes or the ovary, from where are they derived, right? So, from what embryological structure are the testes and the ovaries derived? So, when you talk about these, now this is what is called as the genital ridge. So, the gonads are derived from an embryological structure called as the genital ridge, sometimes often called as the gonadal ridge. So please remember what we have said earlier were genital tubercle, genital fold, genital swelling. Now here what we are writing is genital ridge. What you should know is that the genital ridge appears at 5 weeks of period of gestation in the fetus. Alright, so when does genital ridge appear? It appears at 5 weeks. Now the genital ridge is what, or the gonadal ridge is what is going to form the gonads. So which of the two gonads appears earlier? Is it the testes or is it the ovary? So if you talk about the gonads, then the testes is going to be formed first. It is formed at 7 weeks of POG. And the ovary appears at 8 weeks of period of gestation. So the ovary appears at 8 weeks and the testes appears at 7 weeks. Now what determines that the gonad is going to be a testes or is it going to be an ovary? So that depends on the, does it depend on testosterone? No. So the answer is not testosterone. It actually depends on the presence of SRY gene on the short arm of Y chromosome. So if there is a Y chromosome and it carries the SRY gene, then the gonad which is going to appear is going to be the testes. So the testes, so what gonad is going to appear is going to depend on the karyotype. So if there is a Y chromosome, it's going to be a testes and the determining region is called as the SRY region on the short arm of Y chromosome. Now we come to the ovaries. Now first we look at the gross structure. Now if you talk about the ovaries, the ovary, where is it located? It is located on the ovarian fossa. So ovary is present in the ovarian fossa in the lateral pelvic wall. So in the lateral pelvic wall there is an ovarian fossa and located on this ovarian fossa is the ovary. If we talk about relationships of the ovarian fossa, then superiorly or superior to the ovarian fossa lies the external iliac vessels. So superiorly or superior to the fossa, what is present? External iliac vessels. Posteriorly, what is present? Posteriorly, there is ureter. Okay. I just said that the ovaries are going to appear at 8 weeks. Please listen carefully. I'm already going pretty slow. I'm repeating everything almost twice or thrice. Alright. The testes appears at 7 weeks and the ovaries appear at 8 weeks. Now we are saying that the ovaries are located in the ovarian fossa and we're talking about the relationships of the ovarian fossa. Superiorly is present the external iliac vessels. Posteriorly there are the ureters. And anterior to the fossa, there is obliterated umbilical artery. There is an obliterated umbilical artery anterior to the ovarian fossa. So these are the relationships of the ovarian fossa. Then another thing which is required to know is the ligaments which are attached to the ovary, right? So when you talk about Alright, so when you talk about the ligaments, attached to the ovary, there is an ovarian ligament which we discussed in anatomy, and the ovarian ligament is the one. So the first ligament I'm talking about is the ovarian ligament. The ovarian ligament is the one which attaches the ovary to the uterus. The ovarian ligament attaches the ovary to the uterus. The ovarian ligament is embryologically derived from gubernaculum. The ovarian ligament. Alright, Lucknow, I've read what you're writing. We'll do that for you. Don't worry. Alright. So, ovarian ligament is derived embryologically from the gubernaculum. It attaches the ovary to the uterus. Right. Then the next ligament that we should know is the infundibulopelvic ligament. So next what we talk about is the infundibulopelvic ligament. The infundibulopelvic ligament attaches the ovary to the lateral pelvic wall. See? So the infundibulopelvic ligament attaches the ovary to the lateral pelvic wall. Then there is something which is also called as mesovarium. So there is an ovarian ligament, there is an infundibulopelvic ligament, and finally there is something also called as mesovarium. Mesovarium is a fold of peritoneum, and mesovarium, M-E-S-O, okay, so mesovarium attaches the ovary, it attaches the ovary to the posterior leaf of broad ligament. It attaches the ovary to the posterior leaf of broad ligament. Now, also when you talk about the infundibulopelvic ligament, you have to know that it is the infundibulopelvic ligament which carries the ovarian blood vessels. It carries the ovarian vessels. So the infundibulopelvic ligament carries the ovarian vessels. So ovarian ligament does not carry the ovarian vessels. It is the infundibulopelvic ligament which carries the ovarian vessels. Now this was the gross appearance that we are talking about. If you talk about the microscopic things, then there is again something which is important for you to know. For example, the ovary is divided into a cortex and a medulla. So if you talk about the ovary, it is divided into a cortex and a medulla. So there is going to be a cortex and there is going to be a medulla. Now, the cortex is the one which has follicles. So medulla has no follicles, only the cortex of the ovary has follicles. In fact, the medulla only has blood vessels and connective tissue. So medulla has richly supplied by blood vessels, it has connective tissue and blood vessels, whereas the follicles in the ovary are only present in the cortex. If you talk about the lining epithelium of the ovary, the lining epithelium is single layer cuboidal. The lining epithelium is single layer cuboidal epithelium. Alright. Now, further, if you talk about the ovary would have three types of cells. There are germ cells in the ovary. There are granulosa cells. And there are theca cells. So there are germ cells, there are granulosa cells, and there are theca cells. From what all structures are these derived? So when you call them as germ cells, they are derived from the yolk sac. The germ cells are derived from the yolk sac. If you talk about the granulosa cells, they are derived from the coelomic epithelium. The granulosa cells are derived from the coelomic epithelium. Coming to, from where do we get the theca cells? Now what you have to understand is that the ovary has stroma. Yes, so the ovary, other than the follicles, it has stroma. And when you talk about the ovarian stroma, it has special types of cells called as interstitial cells. So the ovary has ovarian stroma, and the stroma has cells called as interstitial cells. It is these interstitial cells that divide into or mature into two types of cells. The interstitial cells mature into two types of cells. One would be theca cells, and the other are hilus cells. So the stroma has interstitial cells, and the interstitial cells then mature into two types of cells, the theca cells and the hilus cells. So if you are asked from where do we get the theca cells, they are derived from the stroma. And if we talk about from where is stroma derived, the stroma is mesenchymal in origin. The stroma is mesenchymal in origin, or the mesenchymal cells, right? So theca cells are derived from the mesenchymal cells, the granulosa cells are derived from the coelomic epithelium, and the germ cells are derived from the yolk sac. Now there is much more into this derivation and how it happens. Now as we said that the germ cells are derived in the yolk sac, or derived from the yolk sac, the germ cells arise in the yolk sac. Now there are certain events that I'm going to give you. So when you talk about germ cells, the germ cells arise in the yolk sac at 3 weeks of POG. So at 3 weeks the germ cells arise in the yolk sac. Migration of germ cells. The migration of germ cells from the yolk sac to the ovary. The migration of the germ cells from the yolk sac to the ovary occurs at 6 weeks. So 3 weeks they arise in the yolk sac. At 6 weeks they migrate from the yolk sac towards the ovary. At 9 weeks, the germ cells convert into oogonia. At 9 weeks of period of gestation, the germ cells are converted into oogonia. And at 12 weeks, the oogonia form the primary oocyte. At 12 weeks, the oogonia are going to form the primary oocyte. So I'm going to repeat again. At 3 weeks, the germ cells appear in the yolk sac. At 6 weeks, they start migrating from the yolk sac towards the ovary. At 9 weeks, they are going to form the oogonia. And at 12 weeks, the oogonia form the primary oocyte. At 14 weeks, follicle formation begins. The follicle formation in the ovary begins at 14 weeks, and at 24 weeks the follicle formation is completed. So the follicle formation is completed at 24 weeks and it begins at 14 weeks. If you talk about the blood supply to the ovary, The blood supply to the ovary is via the ovarian artery, which is given off from the aorta. So the blood supply to the ovary is via the ovarian artery, which is a branch of aorta given off at the level of L1. So ovarian artery is a branch directly from the abdominal aorta at the level of L1. The venous drainage has also something peculiar. There is going to be a right ovarian vein and there is going to be a left ovarian vein. The peculiarity is that the left ovarian vein first drains into the left renal vein. So the left ovarian vein first drains into the left renal vein and then it drains into the IVC. Alright, so we are saying that the left ovarian vein goes into the left renal vein, it drains into the left renal vein and then it drains into the IVC. Whereas the right renal vein, the right ovarian vein directly drains into the IVC. So the right side, on the right side, it directly drains into the inferior vena cava, whereas on the left side, it first drains into the left renal vein and then it goes to the IVC. If we talk about the nerve supply to the ovary is via the hypogastric plexus. The nerve supply to the ovary is via the hypogastric plexus, and the referred pain from the ovary. The referred pain from the ovary is felt along the medial aspect of the thigh. The referred pain of the ovary is felt along the medial aspect of the thigh, and the nerve through which this travels is the obturator nerve. So the referred pain of the ovary travels via the obturator nerve and it is felt along the medial aspect of the thigh. So this is about the nerve supply. If we talk about the lymphatic drainage, then the lymphatic drainage of the ovary goes into the para-aortic group of lymph nodes. It goes into the para-aortic group of lymph nodes. Alright, so it goes into the para-aortic group of lymph nodes. Now, what we're going to talk about now is going to be oogenesis. Alright. So we have the ovary and we've seen that the primordial germ cells are derived from the yolk sac. Now, when you talk about oogenesis, the first thing to know about oogenesis is that it begins in utero. Oogenesis begins in utero, and to begin with we have oogonia. To begin with we have oogonia. The oogonia are diploid. The oogonia are diploid. They undergo mitotic division. They undergo mitotic division to form the primary oocyte. They undergo mitotic division to form the primary oocyte, and the primary oocyte therefore is again diploid. So the primary oocyte is diploid and it is achieved from the or derived from the oogonia. Next, the primary oocyte enters into the first meiotic division. So the primary oocyte enters into the first meiotic division, but it is arrested. it is arrested in prophase and the stage in which it is arrested is diplotene. So it is arrested in the diplotene stage of prophase 1. Now there's another term we use and it is called as dictyotene stage. So what is dictyotene stage? The arrested phase. The name of the arrested phase is dictyotene. So the arrested or the prolonged phase in which the oocyte is arrested is given a particular name. It is called as dictyotene. So whenever there is an MCQ where you have to choose that the primary oocyte is arrested in which phase, diplotene or dictyotene, both are correct. But a dictyotene is a more specific answer. So the prolonged or the arrested phase is called as the dictyotene stage. If dictyotene is not in the answer, we can very well go ahead and say that it is the diplotene phase or the stage of prophase 1. Right? They are arrested in this phase and the first meiotic division is completed. It is completed at ovulation and it results in the formation of a secondary oocyte and the first polar body. So the first polar body and secondary oocyte are both haploid. The nuclear material is equally distributed between the two. They both are haploid and that is why we say that the first polar body is formed at the time of ovulation. So it is not 24 hours before ovulation. The answer we stick to is at the time of ovulation. The secondary oocyte, as soon as it is formed, enters into the second meiotic division. It enters into the second meiotic division and it is again arrested here. So the secondary oocyte enters into the second meiotic division and it again gets arrested, and this time the arrest is in metaphase. This time the arrest is in metaphase. The second meiotic division is going to be completed. It is not at fertilization, it is completed after fertilization. So the second meiotic division is going to be completed after fertilization and it results in the formation of female pronucleus and the second polar body. So it results in the formation of a female pronucleus and a second polar body. So this is the process of oogenesis. It is a very long process. It begins in utero. Alright, so it's a long process which begins in utero. If you talk about the oocytes, there are certain other things which we want to know about them. So the maximum number of oocytes are present at 20 weeks of period of gestation. Maximum number of oocytes are present at 20 weeks of period of gestation or 5th month intrauterine life. 20 weeks of period of gestation or 5th month intrauterine life, and these are 7 million. These are 7 million. After this, the number keeps decreasing because they enter the process of apoptosis. So at birth, the number of oocytes that remain are 2 million. The number of oocytes that remain are 2 million. At puberty, the number of these oocytes is now 400,000. At puberty, the number of oocytes present is 400,000, out of which only 400 ovulate. So throughout a girl's reproductive life, only 400 oocytes are going to ovulate. So they are 7 million at 20 weeks, 2 million at birth, 400,000 at puberty, and only 400 out of these are going to ovulate. Also, you should remember that with the process of oogenesis, one primary oocyte forms one ovum. Alright, so one primary oocyte with the process of oogenesis will form only one ovum. Now talking about spermatogenesis, unlike oogenesis, which begins in utero, spermatogenesis begins at puberty. It begins at puberty. Now to begin with, we have spermatogonia, and the spermatogonia are again diploid. The spermatogonia divide by mitosis to form the primary spermatocyte. The primary spermatocyte enters into first meiotic division, and it does not get arrested. So there is no arrest. It completes the first meiotic division to form two secondary spermatocytes. Two secondary spermatocyte. Each secondary spermatocyte is haploid. It enters into second meiotic division. There is no arrest. So the secondary spermatocyte enters into the second meiotic division. There is no arrest, and each secondary spermatocyte is going to form two spermatids. So in total, from one spermatocyte we have 4 spermatids, whereas in oogenesis from one oocyte the product was only of one ovum. So here there are 4 spermatids. Now these spermatids undergo certain changes. These spermatids undergo certain changes, and that process is called as spermiogenesis. So it undergoes a process called as spermiogenesis. Now during spermiogenesis, what is happening is certain changes are going to take place in these spermatids to form the sperms. What are those changes? The acrosomal cap of the sperm is derived from the Golgi apparatus. So the acrosomal cap of the sperm is derived from the Golgi body or the Golgi apparatus. The head of the sperm is derived from the nuclear material. The head of the sperm is derived from the nuclear material. The middle piece of the sperm is derived from the mitochondrion, and the tail of the sperm is derived from the microtubules. So the tail is derived from microtubule, the middle piece from the mitochondrion, the head from the nuclear body, and the acrosomal cap forms the Golgi apparatus. Now, spermatogenesis takes 72 days. That is how it is described in our OBGY books. Okay, although some books give it as a range of 70 to 80, but we take it as 72 days. The sperms that are produced by spermatogenesis are non-motile, and they achieve motility. They achieve motility in the epididymis. They achieve motility in the epididymis. A mature sperm has an average length of 55 micron meters. A mature sperm has an average length of 55 micron meters, whereas a mature ovum is much bigger. It measures 120 microns. A mature ovum is much bigger and it is about 120 microns. Now, sperms, as soon as they are released after ejaculation, they enter the female genital tract, and before they can actually fertilize the ovum, they undergo a process called as capacitation. Alright, so capacitation is a process which the sperms undergo before they can actually fertilize the ovum. Now, if you talk about site of capacitation, the broad answer is female genital tract. But to be specific, the major site of capacitation is fallopian tubes. The major site of capacitation is fallopian tubes. We say that the process of capacitation begins in the cervix, but majority of capacitation takes place in the fallopian tube. So if you have to select one answer, what is the site where capacitation takes place? The answer is going to be fallopian tubes. Okay, the answer is going to be fallopian tubes. Then this is different from sperm maturation. If you are asked, where does maturation take place? The answer is epididymis. So capacitation takes place in the female genital tract, whereas sperm maturation takes place in the epididymis. Capacitation, as I've told you, is the process which the sperm has to undergo in order to fertilize the ovum. There are certain chemical reactions which it undergoes in order to fertilize the ovum. Alright? So we are saying that the process of capacitation begins in the cervix, but the major part of capacitation takes place in the fallopian tubes. Also, we are saying that capacitation is different from sperm maturation. If you are asked where does the sperm attain or achieve maturity, then the answer is epididymis. Okay, so they achieve maturity in the epididymis, whereas capacitation is in the female genital tract. Also, you are supposed to know what is the time taken for the process of capacitation. Now, basically, if you talk about capacitation, then during capacitation, three things are going to happen. So, we say that during capacitation or the process of capacitation, three things are going to happen. Three things are going to happen. Those three things are: number one, ability of the sperms to undergo acrosomal reaction. So capacitation mein what is actually happening is, first the sperms achieve the ability to undergo acrosomal reaction. Second, The sperms get the ability to bind the zona pellucida. The sperms get the ability to bind to the zona pellucida of the ovum. And third, during capacitation, the sperms acquire hypermobility. Now again, you have to be very careful. If the question asks you, the sperm attains motility in, the answer is epididymis beyond doubt. But if they are trying to specify and ask you acquire hypermobility, then this is something which is happening during capacitation and the answer changes to female genital tract or majorly in the fallopian tubes. So hypermobility and motility are different, right? So during capacitation, these three things happen. The process of capacitation takes 6 hours. The process of capacitation takes 6 hours. All right, it takes 6 hours. Now, since we are talking about the process of fertilization and things like that, you should know what is the fertilizable lifespan of ovum and what is the fertilizable lifespan of the sperm. So the fertilizable lifespan of the ovum is 24 hours and the fertilizable lifespan of the sperm is 72 hours. So it is 24 hours for the fertilizable lifespan of the ovum and 72 hours as the fertilizable lifespan of the sperm. Where does the process of fertilization take place? So the process of fertilization takes place in the fallopian tube, and to be precise, it takes place in what part of the fallopian tube? In the ampulla. So fertilization takes place in the fallopian tube and in the ampulla of the fallopian tube. Now, the conceptus which is formed called as the zygote remains in the fallopian tube for 3 days. So the conceptus remains in the fallopian tube for 3 days. It remains in the fallopian tube for 3 days and it enters the uterine cavity on day 4. It enters the uterine cavity on day 4. For 3 days after fertilization, it remains in the fallopian tube. Now there are various ways in which the same thing can be put in the options. So we are saying it enters the uterine cavity on day 4. The second thing is that it enters the uterine cavity in 8-cell stage. The third way, it enters the uterine cavity as morula. Now please don't get confused. If you are asked morula is what cell stage, the answer is 16-cell stage. So what is happening is it enters as 8-cell stage and as soon as it enters, it converts into 16-cell. So therefore the answers are different. If they are asking you at what cell stage it is entering into the cavity, it is 8-cell stage. If they are asking you that what is at what stage or in what form does it enter, it is morula. If they ask you morula is what cell stage, it is 16-cell stage. Look, Hubli, you're asking me a question which I usually take up in infertility and I will take it there only, alright? So, you can ask whatever questions you want only once they remain unanswered. I'm sure once you attend my lectures, none of your MCQs would remain unanswered. So, please have patience. I have a sequence in which I usually go. What question you're asking me is a part which I teach in infertility, right? So, I'll not take it up right now. So, what I'm saying it enters the uterine cavity on day 4. It enters in what cell stage? As 8-cell stage. and in what form? In the morula form. So I'm telling you that in case they ask you morula is what cell stage, the answer is 16 cell stage. So what happens is that means it is entering in 8 cell stage, and as soon as it enters, it converts into a 16 cell stage. So morula is definitely 16 cell stage, but it enters the uterine cavity as 8 cell stage. All right. Now, another thing is, when does the first division of the conceptus take place? The first division of the conceptus takes place 30 hours after fertilization. So from a single cell, it will become 2-celled. So the first cell division occurs 30 hours after fertilization. Now please also understand that we've just written 4 on day 4. Now what do we actually mean by this day 4? It means 4 days after fertilization, or on the 4th day after fertilization. This is what it means, on the 4th day after fertilization. So whenever we are writing these days, it means days post fertilization. Now the morula is then going to form a blastocyst. The morula, once it enters the uterine cavity, is going to form a blastocyst. And blastocyst, you are asked, is formed on what day? It is formed on day 5. The blastocyst is formed on day 5. When do you call a morula a blastocyst? So appearance of a fluid filled cavity. Appearance of fluid filled cavity in the morula converts the morula into a blastocyst, and this happens on day 5. It converts the morula into a blastocyst, and this happens on day 5 post fertilization. What happens then? You are also asked, when is zona pellucida lost? When is the zona pellucida lost? So once you talk about zona pellucida, it is the best answer to this question is just before implantation. So the zona pellucida is lost just before implantation, but sometimes they would want to ask you the particular day on which it is happening, as we have mentioned for other stages. So similarly, if we are asked the particular day on which zona pellucida is lost, the answer again is day 5. So the zona pellucida is also lost on day 5 of the, or day 5 post fertilization. After this, what will occur? Implantation. So when does implantation begin? Implantation begins on day 6 to day 7. So if both are in the options, then the best answer is day 6, because it begins on day 6, right? So I'm saying most of the times we give it as a range and we say it is day 6 to day 7. If you have to choose one, it is going to be day 6. Implantation begins on day 6 post fertilization. The implantation occurs in the upper posterior wall. Where does implantation most commonly occur? It occurs in the upper posterior wall in the mid-sagittal plane. So implantation occurs in the upper posterior wall in the mid-sagittal plane. Upper posterior wall in the mid-sagittal plane. Next is, we said that the implantation begins on day 6 to day 7. The next thing is, when is implantation completed? So implantation is completed on day 10. The implantation is completed on day 10. Now, what happens is the cells of the conceptus remain totipotent. The cells of the conceptus remain totipotent up till the 8 cell stage. So they remain totipotent up till 8 cell stage. After this, they are going to divide into 2 types of cells. The trophoblast and the inner cell mass. So the trophoblast and the inner cell mass. The trophoblast is of 2 types. Cytotrophoblast. So the trophoblast, I am saying, is of 2 types. The cytotrophoblast and the syncytiotrophoblast. What is the source of syncytiotrophoblast? So what gives rise to syncytiotrophoblast? So the source of syncytiotrophoblast is nothing but the cytotrophoblast itself. So the cytotrophoblast itself give rise to the syncytiotrophoblasts. The trophoblasts, what do they form? The trophoblasts form the placenta and the fetal membranes. The trophoblast form the placenta and they form the fetal membranes, whereas the inner cell mass is going to form the embryo proper. The inner cell mass is going to form the embryo proper, whereas the trophoblast is going to form the fetal membranes. Once you talk about fetal membranes, the fetal membranes are what all? So the fetal membranes are the amnion, they are chorion, the yolk sac. So the fetal membranes are the amnion, the chorion, the yolk sac and the allantois. So these 4 are called as the fetal membranes. The amnion, the chorion, the yolk sac and the allantois. Related to this, we must know a few questions, which are, out of all these 4 fetal membranes, which membrane is absent in the umbilical cord? And the answer to this question is chorion. So which membrane is absent in the umbilical cord? It is chorion. Then we must know that the amnion is formed on day 8. The amnion is formed by day 8, whereas the chorion is formed by day 10 to day 11. The amnion is formed by day 8 and the chorion is formed by day 10 to day 11. How do you define allantois? Allantois is defined as a diverticulum from the hindgut It is described as a diverticulum from the hindgut that grows into connecting stalk. Now, this is again this year's MCQ, AIPG 2014. And a lot of people marked the answer as Meckel's diverticulum simply because the question asked diverticulum. No, this is how you define allantois. It is the definition of allantois, and the answer to this question was allantois. So allantois is a diverticulum from the hindgut that grows into the connecting stalk. Now, here we also have mentioned umbilical cord, and when you say umbilical cord, the length of the umbilical cord, if you are asked the average length of the umbilical cord, it is 55 centimeters. The average length of the umbilical cord is 55 centimeters, whereas the range of it is 30 to 100 centimeters. So the umbilical cord average length is 55, whereas the range is 30 to 100. So in case they ask you, how do you define a short cord? So a short umbilical cord is one which is less than 30 centimeters. A short umbilical cord is less than 30 centimeters. The umbilical cord has two umbilical arteries and a single umbilical vein. And it is the left umbilical vein which is present in the umbilical cord because the right umbilical vein disappears. The right umbilical vein disappears and only the left is left behind. Also, you must know that the diameter of the umbilical vein is larger than that of the umbilical artery. The diameter of the umbilical vein is larger than that of the umbilical artery. All right. You should also know that it is the umbilical vein which carries oxygenated blood. It is the umbilical vein which carries oxygenated blood from the placenta to the heart of the fetus. So it is the umbilical vein which carries the oxygenated blood from the placenta to the fetal heart, whereas the umbilical artery carries deoxygenated blood. The umbilical arteries will carry the deoxygenated blood. Coming back to trophoblast. So we said that the trophoblasts are going to form the fetal membranes and the placenta. So we discussed the fetal membranes and now we come to the placenta. Now, when you talk about the trophoblast and forming the placenta, we have to know that What forms the placenta? It is the chorion frondosum. The chorion frondosum forms the placenta. The other type of chorion is chorion levae. So chorion is of two types, chorion frondosum and chorion levae. The chorion frondosum forms the placenta, whereas the chorion levae degenerates. Okay, the chorion levae degenerates. Now once you talk about placental formation, they ask you, when is a primary stem villi formed, when is a secondary stem villi formed, and when is the tertiary stem villi formed after fertilization. So when is a primary stem villi formed, when is secondary stem villi formed, and when is tertiary stem villi formed. So the primary stem villi is formed on day 13 post fertilization. The secondary stem villi is formed on day 16 post fertilization, and the tertiary stem villi is formed on day 21 post fertilization. They are all this year's AIPG MCQs. Alright, so primary stem villi day 13, secondary stem villi day 16, and tertiary stem villi day 21. Also, when we were talking about cytotrophoblast, the cytotrophoblasts are also of two types. They are villous cytotrophoblast and there are extravillous cytotrophoblast. So as the name suggests, the villous cytotrophoblast are the ones which take part in the villi formation, whereas the extravillous cytotrophoblast, they invade the myometrium. The extravillous cytotrophoblast, I'm saying, invade the maternal myometrium and the maternal blood vessels. The extravillous cytotrophoblast invade the myometrium and the maternal blood vessels. And when they invade these blood vessels, they make the blood vessels resistant to vasopressors. When the extravillous cytotrophoblast invade the maternal blood vessels, they make the blood vessels resistant to vasopressors. So even if renin or angiotensin or any other vasopressor is going to come, the blood vessel is not going to respond to it by vasoconstricting. It will still remain dilated. That is why the extravillous cytotrophoblast play a very important role. Another difference between the villous and the extravillous cytotrophoblast is that the villous cytotrophoblast lack the HLA antigen. The villous cytotrophoblast lack the HLA antigen. That's the reason why the fetus or the conceptus is not regarded as a foreign body and rejected. This is why, because the villous cytotrophoblast or the cells which are forming the villi itself lack the HLA antigen. On the other hand, the extravillous cytotrophoblast the extravillous cytotrophoblast have the HLA, and the specific HLA which is present only in humans, which is found in these extravillous cytotrophoblast, is HLA-G. The specific HLA which is present in the extravillous cytotrophoblast and which is seen to be present only in humans is HLA-G. And in fact, the presence of HLA-G, so the presence of HLA-G prevents immune rejection of the fetus. The presence of HLA-G in the extravillous cytotrophoblast prevents immune rejection of the fetus. Also, if you talk about the placenta we say has a maternal side and it has a fetal side. So it has a maternal side and it has a fetal side, and by this we don't mean the maternal side is derived from the mother and the fetal side is derived from the fetus. That is not what we mean. The maternal side of the placenta means the side of the placenta which faces the decidua. So the side of the placenta which faces the decidua is called as the maternal side of the placenta, whereas the side which faces the fetus is called as the fetal side of the placenta. Now, I have again introduced another term, and that is decidua. Decidua is nothing but the endometrium of pregnancy. The endometrium of pregnancy is called as decidua. There are 3 types of decidua. Now, this, the marked thing is the myometrium, and the dotted layer is the decidua. Alright, so dotted layer is the decidua. Now, we are saying that the decidua is of 3 types. The decidua which lies below the conceptus. So the one which lies below the conceptus is called as decidua basalis. The decidua which covers the conceptus is called as decidua capsularis. So there is a decidua basalis, there is a decidua capsularis, and the remaining decidua is called as parietalus. The remaining decidua is called as parietalus. Now what is going to happen is, as the conceptus grows, eventually the parietalus and capsularis will fuse together. The conceptus grows and it keeps occupying the uterine cavity. Eventually, the entire space in the uterine cavity is going to be obliterated because the parietalus and capsularis are going to fuse. Now, why are we telling you this? Because there are a few things which you need to know from the MCQ point of view. Number 1. The decidua which is formed by the fusion of parietalus and capsularis is called as decidua vira. So, the decidua which is formed by the fusion of parietalus and capsularis is called as decidua vira. Number 2. The decidua parietalus and capsularis fuse at what period of gestation? I said they would eventually fuse together. So they fuse at 14 to 16 weeks of period of gestation. The decidua parietalus and capsularis will fuse at 14 to 16 weeks of POG. The applied question from this is, or the applied part of this is that this is the time up till which twinning can occur. Because beyond this time, after which the fusion is taking place, beyond this time, the space in the endometrial cavity is completely obliterated, and even if a second conceptus comes, it cannot implant. So, dizygotic twinning is possible only up till 14 to 16 weeks when the decidua parietalus and capsularis have not fused. Once they fuse, this kind of twinning is no longer possible. Alright? So it is called as decidua vira after fusion. The fusion takes place at 14 to 16 weeks, and this is the time up till which twinning can occur. Now, another thing about decidua is that the decidua achieves a maximum thickness of 5 to 10 mm at the end of first trimester. The decidua achieves a maximum thickness of 5 to 10 mm at the end of first trimester. We talked about decidua because we were talking about the maternal side of the placenta, by which we meant that this is the side of the placenta which is going to face the maternal decidua. Now, when you talk about placenta and you talk about the maternal side of the placenta is divided into lobes. The maternal side of the placenta is divided into lobes. How many lobes are there? 15 to 20 lobes. 15 to 20 lobes. Each lobe further is divided into 3 to 5 lobules. Each lobe is further divided into 3 to 5 lobules, and it is the lobule which is called as the functional unit of placenta. It is the lobule which is called as the functional unit of placenta. The total surface area of the villi at term. The total surface area of the villi at term is around 12 meters square. The total surface area of the villi at term is around 12 meters square. The human placenta is described as hemochorial. So what we are saying is that the human placenta is now described as hemochorial. The weight of placenta at term, is 500 grams. The volume of placenta at term is 500 ml. The volume of placenta at term is 500 ml. The ratio of placenta is to fetal weight at term is 1:6. The ratio of placenta to fetal weight at term is 1:6. Then if you talk about the intervillous space, each intervillous space has about 120 spiral arterioles. The intervillous space has about 120 spiral arterioles, and the oxygen saturation of the intervillous space is 65 to 75%. The oxygen saturation of the intervillous space is 65 to 75%. The fetal surface of placenta, what is intervillous space? The space where the maternal blood is going to be present. It is the space between the two villi, intervillous space. So there is going to be one villus tree, and then there is going to be the other villus tree. And the intervillous space is the space which is bathing with maternal blood. Alright, so this is what is called as the intervillous space. The fetal surface of the placenta is smooth and shiny. The fetal surface of the placenta is smooth and shiny because it is covered with fetal membranes. It is smooth and shiny because it is covered with fetal membranes. Placenta takes over the function of corpus luteum. The placenta takes over the function of corpus luteum at 8 to 10 weeks of period of gestation. So beyond this time, it is the placenta which is going to synthesize the progesterone. So the placenta takes over the function of corpus luteum by 8 to 10 weeks of period of gestation. Now we are saying that the placenta is going to synthesize the hormones from this time. So placenta synthesizes progesterone on its own. It synthesizes progesterone on its own, but it uses the precursors. So the precursor for progesterone synthesis by the placenta is maternal LDL cholesterol. Alright, The precursor for the synthesis of progesterone by the placenta is maternal LDL cholesterol, whereas the placenta cannot synthesize estrogen on its own. The placenta cannot synthesize estrogen on its own. It uses the help of fetus. And what does it use? It uses fetal DHEA sulfate. So placenta cannot synthesize estrogen on its own. It takes the help of fetus and it uses fetal DHEA sulfate, which is produced from the fetal adrenal gland. It uses fetal DHEA sulfate from the fetal adrenal gland. This DHEA sulfate is going to travel to the placenta and it is acted upon by two enzymes. The fetal DHEA sulfate reaches placenta and it is acted upon two enzymes. The first enzyme is sulfatase and the second enzyme is aromatase. So the fetal DHEA sulfate is acted upon by sulfatase and aromatase finally to form estrogen. The placenta itself cannot synthesize estrogen. The placenta itself cannot synthesize estrogen because it lacks an enzyme because it lacks the enzyme 17-hydroxylase. This is the reason why it itself cannot synthesize estrogen. It rather uses the help of the fetus and it uses fetal DHEA sulfate, which is derived from the fetal adrenal gland. The DHEA sulfate travels to the placenta. It is acted upon by two enzymes, first by sulfatase and then by aromatase, and finally the estrogen is formed. The specific estrogen of pregnancy is called as estriol. The specific estrogen of pregnancy is called as estriol. Whereas if the question asks you predominant estrogen synthesized by placenta, predominant estrogen which is synthesized by the placenta at term, then the answer remains estradiol. So the predominant estrogen which is synthesized by the placenta at term is estradiol, whereas the specific estrogen of pregnancy is estriol. But what is secreted in maximum amount? It is still estradiol. Placenta also synthesizes other important hormones, one of which is HPL, human placental lactogen. HPL peak levels are reached at 36 weeks. The peak levels of human placental lactogen are achieved at 36 weeks. Human placental lactogen, what is another thing important is that it tells how well the placenta is functioning. So it tells us about the functioning of the placenta. Then the human placental lactogen has anti-insulin activity. So it has an endocrinological action. It has anti-insulin activity. It causes lipolysis and ensures delivery of free fatty acids to the fetus. It causes lipolysis and ensures delivery of the free fatty acids to fetus. It also ensures the delivery of amino acids to the fetus. Another important role, which is yet in the investigational phase, is said that HPL is the main hormone responsible for fetal growth. But this is yet to be proved. Whereas the endocrinological action of HPL is already proven. So it has endocrinological action and it is said to have action on fetal growth. Right? The next important hormone which is synthesized by the placenta is HCG. The next important hormone which is synthesized by the placenta is human chorionic gonadotropin. Now, everything about HCG is in itself a question. And we first begin with the fact that HCG is made up of two subunits, alpha and beta. HCG is made up of two subunits, an alpha subunit and a beta subunit. The alpha subunit is non-specific and the beta subunit is specific. When we say that the alpha subunit is non-specific, it means that the alpha subunit is common to other hormones as well. And the hormones which share the alpha subunit of HCG are TSH, LH and FSH. The hormones which share the alpha subunit are TSH, LH and FSH. HCG is secreted in urine and serum. It is secreted in the urine and serum as early as 8 to 9 days after fertilization. HCG is secreted in the urine and serum as early as 8 to 9 days after fertilization. The beta subunit, which is specific to HCG, the chromosome for beta subunit lies on, or the gene for the beta subunit lies on chromosome 19. The gene for the beta subunit lies on chromosome 19. Now I have said that the alpha subunit is the one which is being shared by a lot of hormones and the beta subunit is specific. But at times there is a question where they ask you, beta subunit of HCG resembles which hormone? So if at all you face a question like that, then you should understand that the beta subunit is quite closely resembling the luteinizing hormone. It differs from the luteinizing hormone by 8 amino acids. So it is quite close in resemblance to luteinizing hormone. If you at all get a question where they ask you, the beta subunit resembles which hormone? The HCG, which is secreted by the placenta, keeps increasing in amount, and the peak value of HCG is reached at 8 to 10 weeks of POG. The value is 100,000. So the peak value of HCG is achieved at 8 to 10 weeks of POG. The value is 100,000. Also, we should know that beyond 10 weeks or after 10 weeks, the HCG values begin to fall. So it reaches a maximum value at that time, and after 10 weeks it begins to fall, and the minimum value is achieved at 16 weeks. The minimum value of HCG is achieved at 16 weeks of period of gestation. After 16 weeks, the value does not fall any further. In fact, the value plateaus. So after 16 weeks, up till term, the value of HCG plateaus. The source of human chorionic gonadotropin, is syncytiotrophoblast. The source of HCG is syncytiotrophoblast. The doubling time of human chorionic gonadotropin is described as 48 hours. The doubling time of HCG is described as 48 hours. It is also described in the form of 1.4 to 2 days. So you could have a question where the options could be in any form. They could be in hours, they could be in days. So when you talk about hours, it is 48 hours, and if you talk about days, it is 1.4 to 2 days. When you say a doubling time, it does not mean simply doubling of the value. When you say doubling, then it means a minimum of 66% increase from the previous value. So when we say that it has doubled, it means a minimum of 66% increase from the previous value. The half-life of HCG is 36 hours. The half-life or T-half of HCG is 36 hours. When you talk about HCG, then there is something called as critical value. For example, what do we mean by critical value is that if we say the critical value for transvaginal sonography, it means at what value of HCG, should the radiologist, when he is doing a transvaginal scan, see the G-sac if it is present in utero? At what value of HCG the radiologist should definitely see the gestational sac if it is present in utero. To explain it further, now Tanda, you're giving the answer, but that's not correct. We're coming to it. There is more into it. So the critical value for transvaginal sonography is described as 1500 international units. The critical value is described as 1500 international units for transvaginal sonography, and the critical value is 6500 international units for transabdominal sonography. Now this means that if I do beta HCG for a patient and the value is more than 1500, alright, I send beta HCG for my patient and the value comes out to be more than 1500, but on TVS the radiologist cannot see a GSAC. Then what is your provisional diagnosis? So if at 1500 the radiologist cannot see a gestational sac in utero, it means the sac is present anywhere outside, yes, and the probable diagnosis is an ectopic pregnancy, right? Whereas at any value less than 1500, we cannot say that we are dealing with an ectopic pregnancy if we don't see the GSAC. So if we don't see the GSAC at values less than 1500, it means we could be dealing with anything. Anything se matlab, it could be either an ectopic pregnancy or it could be a non-viable intrauterine pregnancy, right? Or it could even be a viable intrauterine pregnancy. So till we reach the critical value of 1500, we cannot surely say what type of pregnancy are we dealing with. Now sometimes you are asked not the critical value, but you will be asked the range. So the range for transvaginal sonography is 1000 to 2000 international units. Now some students actually wonder why is the critical value different and why is the range different. Now the answer to that is that ultrasonography is an observer dependent thing. If the radiologist is good, he is experienced, he might be able to see a GSAC even at values as low as 1000. Whereas if the radiologist is not very experienced, then he may not be able to even pick up at values of 2000. That is why, since it is observer dependent, we have a range and we have a critical value. By critical value, it means majority of radiologists will be able to pick up this the GSAC at this value, right? So the range is TVS. So we have three different MCQs which come. One will ask you the range and the answer will be 1000 to 2000. The other will ask you the critical value, which is 1500. And then you can have a third question where they ask you the minimum value of beta HCG at which a GSAC can be seen. The minimum value of HCG at which GSAC can be seen, then the answer is 1000. So three questions on the same thing and three different answers. So if they ask critical value, it is 1500. If they ask you the range, it is 1000 to 2000. Whereas if they ask you the minimum value, it is 1000. We don't have any range for a transabdominal scan. For a transabdominal scan, we have only one value, and that is 6500 international units. Now coming to the uses of HCG. Now, majority of times we are using HCG most commonly to do a urine pregnancy test or simply a pregnancy test. Now, whether you do a urine pregnancy test or you do serum qualitative test. So in the serum you can do two types of test, a qualitative and a quantitative. So I'm saying whether we do a urine pregnancy test or we do a serum qualitative test, the minimum value of beta HCG which can be picked up by these tests is 10 to 20 international units per liter or 10 to 20 milli international units per ml. So there is no difference in the units. If you write international units, it is per liter. If you write milli international units, it is per ml. Whereas if you talk about quantitative serum test, they are much more sensitive. The quantitative serum tests are much more sensitive and they can pick up values as little as 1 to 2 international units per liter or milli international units per ml. So once you talk about quantitative tests in the serum, they can pick up values as low as 1 to 2 international units. When we are doing a urine pregnancy test, then the method we are using is sandwich ELISA. Okay, so the method which we are nowadays using for determination is sandwich ELISA. Alright. Now since we have also asked, or in fact I have talked about GSAC, or to be complete a gestational sac, I would take up a couple of questions asked about it as well. Now a GSAC is the first sign of intrauterine pregnancy. Alright. So the first sign of an intrauterine pregnancy is that we would see a gestational sac. You are asked at what gestations would you see a GSAC on transvaginal ultrasound, and when would you see it on a transabdominal ultrasound? So when you talk about a transvaginal ultrasound, the GSAC can be picked up at 4.5 to 5 weeks. What do we mean by 4.5? It means 4 weeks and 5 days to 5 weeks. Whereas if you talk about a transabdominal scan, it can be seen between 5 to 6 weeks. So again, you have to very carefully see how your question or MCQ is framed. If they ask you a transvaginal ultrasound can earliest pick up gestational sac by, the answer is 4.5 weeks. If they don't specify the type of scan, they simply say ultrasound can pick up gestational sac by what gestation? Now they haven't specified whether they are asking for a transvaginal sac, a transvaginal ultrasound or a transabdominal ultrasound. Then our safest answer is 5 weeks, because we say at 5 weeks GSAC should be picked up by both a transabdominal as well as a transvaginal scan. So when they haven't specified the type of ultrasound, the answer is going to remain 5 weeks, whereas if they specify earliest by transvaginal ultrasound, the answer is 4.5 weeks. Similar things apply to cardiac activity. Alright, similar things apply to cardiac activity. by transvaginal ultrasound, the cardiac activity can be picked up by 5 to 6 weeks. And by transabdominal, it can be picked up by 6 to 7 weeks. So by transvaginal, I am saying cardiac activity can be picked up by 5 to 6 weeks. Whereas by transabdominal route, it can be picked up by 6 to 7 weeks. And what we say is by 6 weeks, cardiac activity should be picked by both transabdominal as well as transvaginal. So if they have not specified the kind of ultrasound and they simply say cardiac activity can be picked up by ultrasound by, the answer is going to remain 6 weeks. Only when they ask you by transvaginal ultrasound, cardiac activity can be picked up by, yes, then the answer is 5 weeks. Alright? Alright. Mysore is asking, what about Doppler? Now, please understand, Doppler is not used routinely to pick up cardiac activity. Doppler is not used routinely to pick up cardiac activity, and when I am writing Doppler here, it means I am talking about ultrasound Doppler. So ultrasound Doppler is not used routinely to pick up cardiac activity because it is not considered safe. Alright, so ultrasound Doppler is not considered safe and therefore it is not used routinely to pick up cardiac activity. In fact, this was your MCQ in May AIMS and November AIMS. Earliest and safest method to pick up cardiac activity is, the answer remains as transvaginal ultrasound, even though the Doppler was one of the options. So if the question says earliest and safest method to pick up cardiac activity, the answer remains a transvaginal ultrasound. Now I tell you what you are asking. See, half of the times when you are asking an MCQ, you don't even know what you are asking, right? You've just read it somewhere, so you want to ask. Now when you are writing and by Doppler, you know which Doppler are we talking about here? It is not ultrasound Doppler. These are handheld Doppler machines which gynecologists use. How do we use these machines? These machines are kept on the maternal abdomen and they would pick up the fetal heart sound. This is what you are asking, that by Doppler, when can we hear cardiac activity? So when you are using a handheld Doppler machine, then the answer is 10 weeks. So by Doppler, the cardiac activity is picked up by 10 weeks. This is not ultrasound Doppler. I'm reminding you again. This is handheld Doppler machine which gynecologists or obstetrician use to pick up or listen to the cardiac activity, and they can be heard at 10 weeks. Now, before you ask me, the next thing is, when do we hear it with stethoscope then? Right? So when do we hear the cardiac activity with stethoscope? The answer is 19 weeks. So by 19 weeks, we can hear it in 50% of patients. And by 24 weeks, we can hear it in 100% of patients. So if you are using stethoscope, we can earliest pick it up by 19 weeks. Whereas if we are using, if we say in 100% cases, then it is by 24 weeks. Alright, coming back to HCG and its uses. So the first we said was diagnosing ectopic and an intrauterine pregnancy. Second, no doubt we use it for molar pregnancy. You use it for diagnosis, we use it for monitoring, everything in molar. We will talk about it when we talk about molar pregnancy. The third important role of HCG. HCG acts as an immunosuppressant and it prevents fetal rejection HCG acts as immunosuppressant and it prevents fetal rejection. Alright. Fourth important role. HCG is one of the stimulus. HCG is one of the stimulus which causes testosterone secretion from the male testes. So it causes testosterone secretion from the fetal testes. So this is also one of the actions of HCG. And then last but definitely not the least important, in fact it is becoming one of the most important uses of HCG. Can anybody tell me what is left in the uses? HCG plays a very important role in screening for Down's syndrome. Okay, HCG plays an important role in screening for Down's syndrome. So what we're going to talk about next is going to be Down's syndrome. Now, Down's syndrome means trisomy 21. Alright, Down syndrome means trisomy 21. Now when we say trisomy 21, it is immaterial whether it is immunosuppressant for the fetus. Had it not been immunosuppressant, it will cause rejection of the fetus. It acts as an immunosuppressant so that the mother does not reject the fetus as foreign body. Right? Coming back to Down syndrome. So I said Down syndrome is trisomy 21. And when you say trisomy 21, it means excess chromosome 21. The excess may be a complete 21 chromosome, or it may be even a segment of chromosome 21 which is extra. So trisomy 21 would mean an extra 21, whether complete or whether partial is immaterial. The most common mode of developing Down syndrome is non-disjunction. In fact, 95% of cases of Down syndrome are due to non-disjunction. 4% cases of Down syndrome are due to translocations. So I'm saying 95% are due to non-disjunction, 4% are due to translocations, and only 1% are due to mosaics. Okay, 1% are due to mosaic patterns, 4% are due to translocations, and 95% are due to non-disjunction. Why is this important to know? The reason is, once you know that majority of cases of Down syndrome are due to non-disjunction, we should know that non-disjunction is not inheritable. Non-disjunction is something which is occurring absolutely by chance during the time of cell division. Alright, so it occurs by chance during the time of cell division. It is not inheritable. So very important, because you get questions where you are seeing that they tell you that a couple, or let's say a lady, has first child suffering from Downs. She has first child suffering from Down's syndrome. And what is her risk? And it was due to non-disjunction. So if The lady has first child suffering from Down syndrome, which was due to non-disjunction. And then they ask you, what is the risk of next baby having Downs? Then, ideally, with what we have told you, that with non-disjunction, it is non-inheritable, the answer should have been 0%. But nothing is 0% in medical science. The risk of having the next baby as Downs would be same as that of any other woman, and the answer is 1%. So if the first child is suffering from Down syndrome, and the cause of that Down syndrome was non-disjunction, then the answer remains, and then they ask you what is the risk in the next baby, the answer is 1%. On the other hand, when the cause of Downs is translocation, then the cause of Down syndrome is translocation, then the risk of next baby suffering from Downs, then the risk of next baby suffering, yes, that's what I said. It is 1%. If it is by non-disjunction, then the risk in the next baby is 1% as that of general population. We are saying the risk is going to be different if the cause is translocation. Okay, it is going to be different if the cause is translocation. So if the cause is translocation, then the risk of next baby suffering from Downs depends on two things. Number one, type of translocation, and number two, who is the carrier of translocation? Is it the mother or is it the father? So if the first baby is suffering from Downs due to translocation, then I am saying the risk of next baby suffering from Downs depends on two things. Number one, the type of translocation, and number two, who is the carrier of this translocation. So, for translocations which are between chromosomes 13, 14, 15 and 21, for the translocations which are between chromosomes 13, 14, 15 and 21, if mother is carrier, the risk of next baby being affected is 10%. Whereas if the father is the carrier, then the risk of next baby suffering from Downs is 3 to 5%. So with translocations between 13, 14, 15 and 21, if the mother is the carrier, the risk is 10%, and if the father is the carrier, the risk is 3 to 5%. Now this risk is not big enough still to ask for abortion. So this is not big enough, so we do not ask for abortion straight away. Alright? You would ask this couple to undergo the diagnostic tests, and then we take the decision whether we will ask the couple to abort the baby or not. So even when we say that the risk, if the mother is the carrier, the risk is 10%, and if the father is the carrier, the risk is 3 to 5%, I am saying this risk is not considered big enough to ask for abortion. So our advice to the couple is going to be undergo the diagnostic test of Downs, and then we will decide. If on diagnostic test we find the baby is suffering from Downs, you can ask for abortion. But if not, then there is no need for an abortion. On the other hand, if the translocation is not between 13, 14 and 15 and 21, rather the translocation is between chromosome 21, 21. So if the translocation is between chromosome 21 and 21, then the risk to next baby is 100%. And in this case, our advice, irrespective of who is carrying it, whether the mother or the father, but if the translocation is between 21-21, the risk of next baby suffering from Downs is 100%, and our advice to the couple is going to be abortion. So these are the kind of questions you get from inheritance pattern. Coming to the screening tests. Now when you talk about the screening test, the screening for Down syndrome can be done in the first trimester, or it can be done in the, I'll give you a break after I finish this part, alright, not much is left. So once I finish this part, I'll give you a break. So the screening for Downs can either be done in the first trimester or it can be done in the second trimester. In the first trimester, the methods used for screening are ultrasound and maternal serum screening. So either we can use ultrasonography or we can use maternal serum screening. Now when we use ultrasonography, what we study is nuchal translucency. Alright, so when we are studying ultrasound, the parameter we see is nuchal translucency. The ideal time to see nuchal translucency is 11 weeks to 13 plus 6 weeks, which means 11 weeks and 13 weeks and 6 days. This is the ideal time to see nuchal translucency. If you talk about maternal serum screening, then the serum screening is done between 11 to 13 weeks. The maternal serum screening in the first trimester is done between 11 to 13 weeks, and the parameters we use are free beta HCG and PAPA. So we use free beta HCG and PAPA. PAPA stands for pregnancy associated plasma protein A. PAPA stands for pregnancy associated plasma protein A. And if the baby has risk of Downs, what will happen? Free beta HCG is more than normal, whereas PAPA is going to be less than normal. Okay, so free HCG is more than normal and PAPA is less than normal. If you talk about second trimester screening, the second trimester, what we study is again serum screening or maternal serum screening. The tests are called as a triple test and a quadruple test. So the tests are called as a triple test and a quadruple test. The time to do second trimester serum screening is between 15 to 20 weeks. The time to do second trimester serum screening is 15 to 20 weeks. The components of the triple test are HCG, alpha fetoprotein, and unconjugated estriol. Unconjugated estriol. If the woman has risk of baby affected by Downs, the HCG is more than normal, alpha fetoprotein is less than normal, and unconjugated estriol is also less than the normal cutoff. If you talk about the quadruple test, then in the quadruple test, the three components remain same. That is, it is going to be HCG, alpha fetoprotein, unconjugated estriol, and the fourth component is inhibin A. The fourth component, which is extra in the quadruple test, is inhibin A. And if asked, or what is the change if the baby is suffering from or has risk of suffering from Downs, then the inhibin A values are more than normal. So HCG and inhibin A are more than normal in a Downs affected baby, whereas alpha fetoprotein, PAPA, and unconjugated estriol are lower than normal. Now please understand that these are only screening tests that we use. Alright? Any time where the screening test comes positive, what we have to do is the confirmatory test. And only thing which is confirmatory for Downs is karyotype. So how do we attain a karyotype in the first trimester? So the diagnostic test of choice for Downs in first trimester is going to be chorionic villus sampling. The chorionic villus sampling can be done any time beyond 10 weeks. Chorionic villus sampling can be done any time beyond 10 weeks. If chorionic villus sampling is done at less than 9 weeks, if chorionic villus sampling is done at less than 9 weeks, then it leads to fetal limb defects. It leads to fetal limb defects and oromandibular defects. This is the reason we stick to chorionic villus sampling only beyond 10 weeks. We don't do it earlier than that. The diagnostic test in the second trimester, is amniocentesis. Amniocentesis can be done any time beyond 15 weeks. Early amniocentesis, that is between 11 to 14, is not done in modern obstetrics. So we don't do early amniocentesis nowadays. The reason is early amniocentesis has high rate of fetal loss, so it leads to abortions. It has high rate of fetal loss, and therefore we don't do early amniocentesis. We only do amniocentesis beyond 15 weeks of period of gestation. Another method by which we can do karyotyping is chordocentesis. So we can do karyotyping by chorionic villus sampling. We can do karyotyping by amniocentesis. And the third method by which we can do chordosynthesis by which we can do karyotyping is chordosynthesis. Chordosynthesis is done anytime beyond 20 weeks. Chordosynthesis is done anytime beyond 20 weeks. And as the term applies, we take blood sample directly from the umbilical vein in the umbilical cord. Another thing that you should know is that amniocentesis, I said, is done after 15 weeks. Usually it is done between 16 to 18 weeks. Most commonly, we perform amniocentesis between 16 to 18 weeks. I said in the second trimester, it is amniocentesis which we do. Chordosynthesis is a high risk procedure as compared to amniocentesis. We don't do chordosynthesis, but it can be used to do karyotyping. Why I'm telling you this? Because there is a question which has a probability or has been asked in fact in future, in past as well, is by all the methods karyotyping can be done except, and the options are going to be chorionic villus sampling, amniocentesis, chordosynthesis, and the fourth option is going to be fetal skin biopsy. So you have to know that fetal skin biopsy is not used for karyotyping. As of now, it is being used only to determine certain specific diseases which affect the skin. So karyotyping is being used or can be done by any of these three methods, but not by fetal skin biopsy. Alright, so with this, we finish this section and we take a break. And it's almost 5:45, so we meet at 6 p.m. Alright. Yes, I'll ask the coordinator to put up whatever your missed part is in the break time. Alright, so we start the class at 6, alright? To start now is the next thing, and we're going to take up physiological changes in pregnancy. And what we're going to start with is signs which may be seen in pregnancy. So when you talk about the signs, the first is the Chadwick's sign. The Chadwick's sign is also called as the Jacquemus sign. Don't worry, I've had a word with these people. They will put it up at the end of the class. They'll put up whatever you have missed. They'll put it up. All right. See, Mirage, spermatogenesis is only 72 days. 16 days are taken from the travel from the testes to the epididymis. So somewhere in some guides it is written as 90. It is not. The spermatogenesis per se is not 90 days. It is 72 days. All right. Okay, so when you talk about the Chadwick sign, it is also called as the Jacquemus sign. Okay, it is also called as the Jacquemus sign. What is it? It is the bluish discoloration of cervix and vagina. And the Jacquemus sign can be seen at 8 weeks. Okay, it can be seen at 8 weeks. Hagar's sign. Hagar's sign is softening of the lower uterine segment. The softening of the lower uterine segment is called as the Hagar's sign, and it can be seen as early as 6 weeks. Alright, it will be seen as early as 6 weeks is Hagar's sign. Then there is something which is called as Goodell's sign. Goodell's sign is softening of cervix, which is called as the Goodell's sign, and again this is seen at 6 weeks. Then there is Piscasex sign, which is one half of uterus feels softer than the other half. So one half of uterus feels softer than the other half due to lateral implantation. So due to lateral implantation, one half is softer than the other half. Then the next sign is called as Osiander's. Piscasex sign, which I said, when one half is softer than the other half due to lateral implantation, is seen at 8 weeks. Okay, it is seen at 8 weeks. Talking about Osiander's sign. Osiander's sign is lateral vaginal fornicial pulsations. So if the examiner puts her fingers in the vaginal fornix, then we can feel pulsations due to increased vascularity. So this is called as the Osiander's sign, and it is again seen at 8 weeks. Finally, there is a Palmer's sign. Palmer's sign is regular rhythmic uterine contractions. Palmer's sign is regular rhythmic uterine contractions. Again, can be seen as early as 8 weeks. It can be seen as early as 8 weeks. Two other signs which we must know. One is called as the Hartmann's sign. Okay, so one is called as the Hartmann's sign. Hartmann's sign is implantation bleeding. So when there is implantation going on, the woman may experience some amount of vaginal bleeding, and this is called as the Hartmann's sign. Similarly, Wimberg's sign is for abdominal pregnancy. Wimberg's sign is seen in abdominal pregnancy because what do we see in the Wimberg sign? We see that the fetal spine would be overlapping the maternal spine. So Wimberg sign is seen in abdominal pregnancy. Then if you talk about pregnancy, cloasma or melasma is the physiological coloring or color change in pregnancy which is seen in pregnant females, and this is called as the mask of pregnancy. This is seen on face, called as cloasma and melasma. The average weight gain in pregnancy is 12.5 kgs. The average weight gain in pregnancy is 12.5 kgs. The amount of extra water retained or acquired in pregnancy, amount of extra water acquired in pregnancy is 6.5 liters. Wimberg sign, I said that it is seen in abdominal pregnancy, and this is when you see that the fetal spine and the maternal spine overlap. Okay, when the fetal spine and maternal spine overlap, it is called as the Weinberg sign. We don't take anything as the rate of weight gain in pregnancy. If it's something given like that in your guidebooks, there is no standard criteria for rate of weight gain. Okay, there is no rate of weight gain. We don't use those criteria any longer. All right. So we're saying the amount of extra water acquired in pregnancy is 6.5 liters. When you talk about anemia in pregnancy, we define it as less than 11 gram percent. Less than 11 gram percent. The total iron requirement in pregnancy is 1000 milligrams. The total iron requirement in pregnancy is 1000 milligrams. Sometimes they often ask, what is the iron requirement in the second half of pregnancy? So in the second half of pregnancy, the iron requirement is 6 to 7 milligrams per day. In the second half of pregnancy, the iron requirement is 6 to 7 milligrams per day. If you in general talk about the blood picture, then in pregnancy there is going to be leukocytosis. Leukocytosis is physiologically seen in pregnancy, and among the leukocytes we see relative neutrophilia. We see relative neutrophilia. So we are saying that leukocytosis is physiological in pregnancy, and among leukocytosis there is relative neutrophilia. If you talk about the platelet count, then we say the average platelet count slightly decreases. The average platelet count slightly decreases. What is in general about the coagulation factors? Then we say all coagulation factors increase. All coagulation factors increase in pregnancy except 11 and 13. All coagulation factors increase in pregnancy except 11 and 13. Now these physiological changes were very general ones, and then we take up the ones which are specific to the organ systems. For example, if we talk about the renal system, what are the physiological changes which occur? Then we say both kidneys increase in size by 1 centimeter. Both the kidneys increase in size by 1 centimeter. GFR increases in pregnancy by 50%. GFR increases in pregnancy by 50%, and that is why we say that the serum creatinine and blood urea nitrogen, serum creatinine and BUN or blood urea nitrogen decrease in pregnancy. They decrease in pregnancy. In pregnancy, there is a physiological ureteral dilatation. So we can see a physiological hydroureter and hydronephrosis. We can see a physiological hydroureter and hydronephrosis, and the reason for this is progesterone. The progesterone has a relaxant action. It has a relaxant action, and thereby it produces ureteral dilatation. Okay, it produces ureteral dilatation, and it is important to know that the right side ureter dilates more than the left side. So hydroureter changes are more common on the right side. The reason for this is because a normal uterus in pregnancy, the normal uterus in pregnancy is present in dextrorotation. So the normal uterus in pregnancy is dextrorotated. So what happens is, once it is dextrorotated, it means tilted towards the right side. It presses the right ureter more at the pelvic brim. So it presses the right ureter more at the pelvic brim, and therefore the proximal ureter would show dilatation, which is more than on the left side. That is why we say that the hydronephrosis is more common on the right side as compared to the left side. Talking about the physiological changes of the cardiovascular system. Now, once you talk about the cardiovascular system, we say that the plasma volume increases by 40%. The plasma volume increases by 40%. The red blood count or volume, RBC volume, increases by 20%. This is why we see physiological hemodilution in pregnancy. So this is the reason why we see a physiological hemodilution. Another applied MCQ from these two values is what happens to the oxygen carrying capacity of blood in pregnancy. So you should know oxygen carrying capacity in pregnancy decreases, because oxygen carrying capacity is not a function of RBC mass. Oxygen carrying capacity is a function of hemoglobin, which is falling. Then the cardiac output in pregnancy, increases by 40%. Therefore, and if you talk about oxygen demand of the tissues, it increases by only 20%. So cardiac output is more than what is required by the tissues, right? The rise in cardiac output is more than what is required by the tissues, and therefore we write arteriovenous oxygen gradient. The arteriovenous oxygen gradient in pregnancy falls. The arteriovenous oxygen gradient in pregnancy falls because the rise in cardiac output is more than the oxygen requirement of the tissues. Heart rate in pregnancy increases by 20%. The heart rate in pregnancy increases by 20%. And when asked in beats per minute, we say that the heart rate increases by 10 to 18 beats per minute in pregnancy. So it increases by, we say, either 20% or 10 to 18 beats per minute. Other physiological changes are all heart sounds are loud in pregnancy. All heart sounds are loud. There is a physiological systolic murmur which is up to grade 2. There is a physiological systolic murmur which is up to grade 2. There is a physiological splitting of S1. There is a physiological splitting of S1. A physiological S3 can be heard. A physiological S3 can be heard. If you talk about the ECG of the patient, Then the physiological changes in the ECG which we can see are left axis deviation. So left axis deviation is a physiological change we see, and along with this we see ST and T wave changes, and we can also see extrasystole. So in pregnancy there is a physiological left axis deviation, there is ST and T wave changes, and there are presence of extrasystole. If you talk about the chest X-ray of the patient, then in chest X-ray we see that the cardiac silhouette appears larger. Now please understand, only the cardiac silhouette appears larger, there is no cardiomegaly, alright. Because of the positioning of the heart in pregnancy, the cardiac image on the chest X-ray appears larger, but there is no cardiomegaly. So it is only that the cardiac silhouette appears larger. Secondly, there is straightening of the left heart border. There is straightening of the left heart border, which is again a physiological change in the pregnancy. Then the next system we talk about is the respiratory system in the mother. So if you talk about the respiratory system, what all should we know? There is increase in alveolar ventilation by 40%. There is increase in the alveolar ventilation by 40%, and there is increase in the tidal volume. But this increase in tidal volume and alveolar ventilation is not because of increase in the respiratory rate. So in the respiratory rate there is no change in pregnancy. Then how is a pregnant woman increasing her alveolar ventilation or tidal volume? She does it by increasing the depth of respiration. So only the depth of respiration is increasing. There is no increase in the respiratory rate. We would also ask you, and in fact it was one of your AIPG MCQs, what is the stimulus for this increase in the depth of respiration? So the stimulus for the increase in the depth of respiration is progesterone. How does progesterone become a stimulus? It increases the sensitivity of the respiratory center. It increases the sensitivity of the respiratory center. So it increases the sensitivity of the respiratory center to carbon dioxide. Now since the respiratory center becomes more sensitive, what is going to happen? There is going to be a carbon dioxide washout. So if we are asked what happens to PCO2 in pregnancy, then the answer is decreases. PCO2 decreases in pregnancy. Now since PCO2 decreases, what kind of alkalosis is it? It is respiratory alkalosis. Again, this was one of your AIPG MCQs. So we say pregnancy is a state of mild respiratory alkalosis. Pregnancy is a state of mild respiratory alkalosis. Now once we say that, you would be asked what happens to pH in pregnancy. Now since we are saying it is alkalosis, does not mean that there is going to be a change in the pH. please understand we have put a word in front of it and it is mild. So there is no change in the pH because there is going to be renal compensation. So the kidneys are going to compensate for this respiratory alkalosis. And how do they compensate? They compensate by increasing bicarb excretion. So they compensate by increasing the bicarb excretion. Therefore, the serum levels of bicarbonate decrease in pregnancy. The serum levels of bicarbonate decrease in pregnancy. Now, other things in relation to the respiratory system that we need to know is that we all know that the gravid uterus moves into the abdomen, and when it moves into the abdomen, it is going to push the diaphragm up. So the diaphragm moves up by 4 centimeters. So the diaphragm in pregnancy rises by 4 centimeters. In order to balance this, what does the woman try and do in order to balance this disturbance? There is an increase in the transverse thoracic diameter by 2 centimeters. So in order to balance this upward movement of diaphragm, there is an increase in the transverse thoracic diameter by 2 centimeters. Now please understand, it is only trying to balance. The diaphragm was rising by 4 centimeters, but the transverse thoracic diameter has increased only by 2 centimeters. So it tries to balance, but it cannot balance it completely. Therefore, the total lung capacity in pregnancy decreases. The total lung capacity in pregnancy decreases, but the vital capacity does not change. There is no change in the vital capacity. Why? Because in order to manage with the total lung capacity which is decreased, expiratory reserve volume decreases. So the total vital capacity does not change. It is the expiratory reserve volume which decreases. And if you talk about inspiratory reserve volume, there is again no change. There is no change in the inspiratory reserve volume. Now, this was in relationship to the physiology of the mother. Now, if you talk about certain changes in the fetus, then what all you should know? So the first thing is, if we talk about the fetus, we have talked about fetal cardiac activity. It appears on day 21 post fertilization. So cardiac activity is day 21 post fertilization, or 5 weeks from the last menstrual period. So day 21. So this is also asked in the same way as fetal circulation is established by. So fetal circulation is established by day 21 post fertilization. A similar question is, when is placental circulation established? So the placental circulation is established, just reverse this 21, the answer is 12. So the placental circulation is established by day 12. I am quoting Langman's embryology on this. Why I am specifically telling you this? Because this is a point where Langman's and Williams obstetrics differ. So as per Langman's, the answer is day 12, whereas Williams obstetrics gives it as day 17. Placental circulation is established by day 17. As to which answer we stick to what is given in Langman's embryology, since it is actually an embryology question. So a better answer is day 12, post-fertilization. Similarly, what is the uterine blood flow at term? What is the uterine blood flow at term? The uterine blood flow at term is 750 ml per minute. The uterine blood flow is 750 ml per minute, and this represents 10% of the cardiac output. The uterine blood flow is 750 ml per minute, and this represents 10% of the cardiac output. Another question which may sound similar but it is actually different is, what is the placental blood flow at term? So what we wrote just now was uterine blood flow at term, but now we are talking about the placental blood flow at term. So if you talk about the placental blood flow at term, then it is 450 to 650 ml per minute. 450 to 650 ml per minute, and this represents 90% of blood flow to the uterus. So 90% of whatever blood comes to the uterus is given to the placenta, and 10% the uterus uses for its own metabolic needs. So this represents 90% of blood flow to the uterus. Also, a fact which was asked recently, ovarian vascular pedicle. Ovarian vascular pedicle dilates by how much in pregnancy? So the answer here is that the ovarian vascular pedicle dilates 3 times in pregnancy. It dilates 3 times in pregnancy. Similar question to blood volumes is, what is the fetal blood volume at term? What is the fetal blood volume at term? Then we say that the fetal blood volume at term is 125 ml per kg. It is 125 ml per kg. Gross fetal movements. When do the gross fetal movements appear? They appear at 8 weeks. Gross fetal movements appear at 8 weeks. Fetal breathing movements. The fetal breathing movements appear at 11 weeks. Fetal swallowing movements appear at 10 to 12 weeks. So if they ask earliest, the answer would be 10 weeks. So fetal swallowing can be seen as early as 10 weeks. Breathing movements 11 weeks. Gross fetal movements 8 weeks. Fetus begins to pass urine at 12 weeks. Begins to pass urine at 12 weeks. External genitalia. External genitalia can be differentiated into male and female again at 12 weeks. External genitalia can be differentiated into male and female by 12 weeks. The fetus can pass meconium. The stool of the fetus is called as meconium, and we say that the fetus can pass meconium as early as 16 weeks. The fetus can pass meconium as early as 16 weeks. Alright, so these are certain values from the fetal part of it. And then when we say we are doing physiology, then we can't miss on amniotic fluid, right? So the amniotic fluid forms an important part of the physiology. You will definitely get some or the other question from this part. So when you say amniotic fluid, the first thing we talk about is what is the source. So what is the major source of amniotic fluid in the first trimester? So in the first trimester, the major source of amniotic fluid is an ultrafiltrate of maternal plasma. So in the first 12 weeks, the major source of amniotic fluid is an ultrafiltrate of maternal plasma. From 12 to 20 weeks, the major source of amniotic fluid is transudate from the fetal skin. And beyond 20 weeks, the major source of amniotic fluid is going to be fetal urine. Again, it is this year's AIPG question, where what did they ask? They asked, what is the major source, or when is fetal urine the major source of amniotic fluid? So when you talk about fetal urine being the major source, the answer is going to be 20 weeks. So it is the major source of amniotic fluid only beyond 20 weeks. If you talk about pH of the amniotic fluid, it is between 7 to 7.5. Most of the textbooks give it as a range, but if you have to choose one value, then it is as close to 7 as possible. Alright, it is as close to 7 as possible. The water in the amniotic fluid, is replaced every 3 hours. The water in the amniotic fluid is replaced every 3 hours. Again, AIPG 2014. Then, what is the turnover rate of amniotic fluid at term? What is the turnover rate of amniotic fluid at term? The answer is 500 ml in 24 hours. The turnover rate is 500 ml in 24 hours. What is the osmolarity? It is 250 milliosmoles. 250 milliosmoles is the osmolarity. Then, if we talk about amniotic fluid, normally we say that the amniotic fluid is clear. So, in normal circumstances, the amniotic fluid is clear. But in certain specific conditions, there are color changes in the amniotic fluid. For example, if we say green, then this is seen in meconium staining. Green colored amniotic fluid is seen with meconium staining. Golden color amniotic fluid is seen with RH incompatibility. Golden colored is seen with RH incompatibility. Then greenish yellow. Greenish yellow, also described as saffron. Greenish yellow or saffron is seen in post maturity. So greenish color or saffron seen in post maturity. Then dark brown color. The dark brown color of amniotic fluid is seen with an IUD baby. So when the baby dies in utero, the amniotic fluid achieves a dark brown color. It is seen in intrauterine death. This is sometimes also described as tobacco juice appearance. So it appears like tobacco juice. It is seen in IUD. And when you only describe it as dark colored, then this is seen with abruption. Dark colored amniotic fluid is seen with abruption. The amount of amniotic fluid present at 12 weeks is 50 ml. At 20 weeks, it is 250 ml. At 28 weeks, it is 1 liter. At 36 weeks, it is 900 ml. At 40 weeks, 800 ml. And at 42 weeks, 200 ml. The absolute amount of amniotic fluid has been asked in various exams over and over again. So at 12 weeks 50 ml, 20 250 ml, 28 1 liter, 36 weeks 900 ml, 40 weeks 800 ml and then 200 ml. So maximum amount of amniotic fluid is present at 28 weeks and not 36 weeks as might be given in your guidebooks. So the maximum amount of amniotic fluid is present at 28 weeks, the amount being 1 liter. Although the amount at 36 weeks is not very less, it is 900 ml, but it is definitely less than that at 28, right? So sometimes this question comes in the form of range. Amniotic fluid is maximum at what POG? And then the ranges are in the form of 34 to 36 weeks and the other option is going to be 36 to 38. So we take it as 34 to 36 weeks when it comes as a range. Alright, if it comes as a range, we are saying that we would take it as 34 to 36 and not as 36 to 38 weeks. Maximum at 32 or 28 weeks. See, as of the table, this table that I've given you, this is a table from Williams Obstetrics 23rd edition. As regard of the value, if 28 is in the option, then the safest bet is 28 weeks. Alright, so this is a direct table from Williams Obstetrics. It is not my interpretation of any data. So it clearly states that it is 1 liter at 28 weeks, and if 28 weeks is in the option, you should go with 28 weeks. Alright. Now, if you talk about functions of amniotic fluid, then again, Mysore, please don't jump. Cardiac output is something which I am going to take when I teach heart disease. Alright, let things remain relevant. We are not answering one question here, right? So when we come to heart disease and pregnancy, I shall give you that value as well, right? So coming to functions of amniotic fluid. So when you talk about functions of the amniotic fluid, the question usually is in the form of all our functions of amniotic fluid except. So amniotic fluid is going to do a lot of functions. It is protective for the baby. It helps in the movement of the baby. It acts as a shock absorber. Now, it provides space for symmetric growth. So it is doing a lot of functions, but please remember, amniotic fluid has no role in fetal nutrition. It has no role in fetal nutrition, right? It has no role in fetal nutrition. So usually that is the answer when we say that what happens to amniotic or all our functions of amniotic fluid except, and the except is going to be fetal nutrition. Then we come to how do we measure the amount of amniotic fluid. How do we measure the amniotic fluid? So when we measure amniotic fluid, it is done by a method which is called as AFI. Alright, it is called as amniotic fluid index. Amniotic fluid index is something which we measure on ultrasonography, and the normal value of amniotic fluid index is 8 to 24. The normal value of amniotic fluid index is 8 to 24. More than or equal to 25. More than or equal to 25 is called as polyhydramnios. An absolute value of 2 liters is also called as polyhydramnios. And long term back, the method used to describe amniotic fluid index was DVP. Alright, it was DVP, deep vertical pocket. It is not used nowadays, but still you should know what value in DVP would account to polyhydramnios. So a value of 8 or more is described as poly in deep vertical pocket. Kolhapur, I actually don't know what you've written, 5 to 20, but whatever you've written is not correct. Right? So I've given you what the normal value is. It is 8 to 24. Coming to how do you define oligo similarly. So when you say oligo, the amniotic fluid index is less than 5. So please remember, between 5 to 8 is borderline. The normal value is 8 to 24. More than or equal to 25 is poly, and less than 5 is called as oligo. The absolute value of amniotic fluid, to call it as oligohydramnios, has to be less than 200 ml. And the value of DVP, to call it as oligo, should be less than 2. So these are the various cutoffs to describe polyhydramnios and oligohydramnios. Right? Now, if we say what is the most common cause of mild polyhydramnios. So please remember the term here is mild, and the most common cause of mild polyhydramnios is idiopathic. The most common cause of mild polyhydramnios is idiopathic. Whereas if the question changes and it says most common cause of moderate to severe poly, then the answer to this question is gross congenital anomalies. The most common cause of moderate to severe polyhydramnios is gross congenital anomaly in the baby. Now, which GCA is responsible for polyhydramnios? Then GIT anomalies are most common, followed by neural tube defects. So the most common anomalies to cause polyhydramnios in the fetus, or moderate to severe amount of polyhydramnios in the fetus, are GIT followed by neural tube defects. Similarly, if the question asks, what is the most common cause of oligohydramnios? What is the most common cause of oligohydramnios? The answer remains the same as idiopathic. The most common cause of oligo is idiopathic. Whereas if they ask, which gross congenital anomaly is most commonly associated with severe oligo, then the answer is bilateral renal agenesis. The most common congenital anomaly to be associated with severe oligohydramnios is bilateral renal agenesis. It is bilateral renal agenesis. For simple reasons, you should understand that any anomaly which inhibits swallowing of the baby, any anomaly which inhibits swallowing of the baby will lead to poly. Take? So, problems where the baby cannot swallow will lead to poly, whereas problems where the baby cannot urinate will lead to oligo. Alright, the problems where the baby cannot urinate will lead to oligo, whereas the problems where the baby cannot swallow will lead to polyhydramnios. Alright, so with this we finish the physiological changes in pregnancy and we move on to the next topic, and it's going to be labor. Alright, so again when we talk about labor, there are going to be lots of values and a lot of conceptual things as well. So we'll try and make it as clear as possible and give you the concepts as well. So when you talk about labor, there are 4 stages of labor. So there is a first stage, second stage, third stage and fourth stage. Now when you talk about the first stage of labor, it begins from the onset of true contractions. So first stage is from the onset of true labor pains to full dilatation of the cervix. And the first stage of labor is divided into a latent phase and an active phase. So there is a latent phase and an active phase. And if we are asked at what cervical dilatation does active phase of labor begin, then the answer is 3 centimeters. So any dilatation beyond 3 centimeters marks the beginning of active phase of labor. So latent phase of labor is between 0 to 3 centimeter dilatation, and anything above 3 centimeter dilatation marks the onset of active stage of labor. Irrespective of whether the question says WHO or it says ACOG, we take uniform criteria and it is beyond 3 centimeters of dilatation. Now when you talk about the first stage of labor, especially the latent phase, we divide it into nulliparous women and multiparous women, and into what is called as normal and what is called as prolonged. So what is normal and what is prolonged? So normal duration in nulliparous women is 12 hours and in multiparous it is 8 hours. For prolonged it is 20 hours as the cutoff in nulliparous and 14 hours as the cutoff in multiparous. Now as I said, this is more true, these cutoffs are more true for the latent phase of labor. Whereas when you talk about active phase of labor, then instead of talking about the absolute hours, we talk about the rate of cervical dilatation and the rate of descent of head. So if you talk about rate of cervical dilatation, the rate is different in nulliparous and in multiparous. So in nulliparous women, the rate of cervical dilatation is 1.2 centimeters per hour, whereas in multiparous women, it is 1.5 centimeters per hour. Similarly, if you talk about rate of descent of head, then we again divide it into nulliparous and into multiparous. Rate of descent of head in nulliparous is 1 centimeter per hour, whereas the rate of descent of head in multiparous is 2 centimeter per hour. It's all there on the notepad itself. So we said that the first stage begins from the onset of true labor pains to full dilatation. And then we said that it is divided into a latent phase and into an active phase. The latent phase is described from 0 to 3 centimeter dilatation, and the active stage means anywhere beyond 3 centimeter dilatation. For latent stage, we have cutoffs depending on whether the woman is nulliparous or multiparous. So for nulliparous, the normal duration is 12 hours, and for multiparous it is 8 hours. To call it prolonged, it has to be 20 hours in nulliparous and 14 hours in multiparous. In the active stage, I said we don't deal with absolute hours, we deal with rate. So the two rates we talk about is rate of cervical dilatation and rate of descent of head. The rate of cervical dilatation in nulliparous is 1.2 centimeters per hour, and in multiparous it is 1.5 centimeters per hour. Whereas the rate of descent of head in nulliparous is 1 centimeter per hour, and that in multiparous is 2 centimeter per hour. Talking about the second stage of labor now. The second stage of labor is from full dilatation to expulsion of the fetus. From full dilatation to expulsion of the fetus. Again, you have cutoffs for normal and prolonged. We make a similar table of nulliparous and multiparous. Normal and what is prolonged. So in nulliparous, the normal duration for the second stage of labor is 1 hour. For multiparous, it is 30 minutes. To call it prolonged, the cutoff for nulliparous is 2 hours and the cutoff for multiparous is 1 hour. Now here we also have a newer third column. The third column is what are the cutoffs if the woman has received epidural analgesia? What are the cutoffs if the woman has received epidural analgesia? Then the cutoffs in nulliparous become 3 hour and the cutoff in multiparous becomes 2 hour. So this means that epidural analgesia, which we give for painless labor, prolongs the second stage of labor by about 1 hour. It prolongs the second stage of labor by about 1 hour. If you talk about the third stage of labor, it is from the expulsion of the fetus to the expulsion of placenta. The average duration of the third stage of labor is 15 to 20 minutes. the average duration of the third stage of labor is 15 to 20 minutes, and in order to call it prolonged, it should be more than 30 minutes. In order to call it prolonged, it should be more than 30 minutes. The fourth stage of labor is the period of observation, and it is for 1 hour. So it is a period of observation of the woman for 1 hour after delivery. So it is a period of observation of the woman for 1 hour after delivery. Now what we are going to talk about is, actually what questions you get are from dystocia of labor or abnormal labor, but certain concepts have to be clear from normal labor before we can actually go on and discuss abnormal labor or dystocia or various other abnormalities that can be present. So if you talk about normal labor, first we talk about certain definitions that you should be knowing in order to proceed in labor, because otherwise I will not be able to explain you things. So we'll first discuss certain basic definitions. The first one being a lie. So when you say lie, it is the relation between long axis of fetus to maternal spine. So it is the relation between the long axis of the fetus to the maternal spine, which is called as lie. So the baby who is present like this, so this is the maternal spine, this is called as a longitudinal lie. Similarly, if this is the maternal spine and the baby is present like this is also longitudinal lie. If this is the maternal spine and the baby is present like this, then this is a transverse lie. Whereas if this is the maternal spine and the baby is present like this, it is called as an oblique lie. Oblique lies are sometimes also described as unstable lie. The first MCQ from this very basic thing is, what is the most common cause of an unstable lie? At term. So the most common cause of an unstable lie at term is placenta previa. The most common cause of an unstable lie at term is placenta previa. Then we come to presentation. Now presentation is the part of the fetus which first enters the birth canal. Right? So if we go back to figure 1, this is longitudinal lie but cephalic presentation, because the head is going to enter the pelvis first. This is again a longitudinal lie but breech presentation, because the buttocks are going to enter the pelvis first. A transverse lie is called as shoulder presentation. A transverse lie is called as a shoulder presentation. And when you talk about an unstable lie, so we don't say any presentation in this case because the unstable lie would eventually convert either into a transverse or into a longitudinal lie. And then we would describe what the presentation is. Now, please understand when the presentation is cephalic, it can be further divided into various other types of presentations, that is vertex, face and brow. So cephalic presentation is further divided into 3 more types of presentation: vertex, face and brow. Now vertex presentation कब होती है? When the head is fully flexed. So in cephalic, when the head is fully flexed, then the presentation is vertex. When the head is fully extended, then the presentation is face. And when it is partial extension, extension, then it is brow presentation. So depending on the degree of flexion and extension of the neck, the presentation can become vertex, it can become face, or it can become brow. We'll go on to more details of this. First, you should also know what is engagement. So engagement is when the biparietal diameter of the fetal head crosses the pelvic brim. So when the biparietal diameter of the fetal head crosses the pelvic brim, it is called as engagement. Now, why do we lay so much stress on engagement? The reason is that engagement, once it occurs, it rules out CPD, that is cephalopelvic disproportion. So once engagement occurs, it rules out CPD at the pelvic inlet. So if engagement is occurring, it almost tells you that there is going to be no CPD at the level of pelvic inlet. Engagement in primi gravida occurs at 37 weeks. Engagement in primi gravida occurs at 37 weeks. Whereas engagement in a multigravida occurs during labor. Okay, it occurs during labor. Now, when you talk about engagement, there are also engaging diameters. The fetal head has 2 engaging diameters, out of which one is always constant. So one engaging diameter is BPD. So biparietal diameter is the transverse engaging diameter of the fetal head. But the antero-posterior engaging diameters the antero-posterior engaging diameter keep changing depending on degree of flexion and extension. So they keep changing depending on the degree of flexion and extension. For example, we said when it is vertex presentation, the head is fully flexed. They will ask you, what is the engaging diameter? So the engaging diameter when the head is fully flexed or in vertex presentation is suboccipitobregmatic. It is suboccipitobregmatic and it measures 9.5 centimeters. Similarly, when the neck is fully extended and the presentation is space, then the engaging diameter, the engaging AP diameter becomes submentobregmatic. It becomes submentobregmatic. It also measures 9.5 centimeters. When there is a partial extension, that is in the brow presentation, when there is partial extension, जो हमने पढ़ा in the brow presentation, then the engaging diameter becomes mento-vertical. The engaging diameter becomes mento-vertical and it is 14 centimeters. The engaging diameter becomes mento-vertical, which is 14 centimeters. Certain other diameters of the fetal head which are important are biparietal 9.5, bitemporal 8 centimeters, and the shortest being bimastoid 7.5 centimeters. So mento-vertical is the largest, 14 centimeters, and bimastoid is the shortest, measuring 7.5 centimeters. Certain diameters are important in the female pelvis as well. So not all of them are important, but some of them are important for us. And when you talk about the female pelvis, there are three aspects of it. One is an inlet, then is the cavity, and then is the outlet. So for us, the shortest diameter of each becomes most important for us to know. And in inlet, the shortest diameters are antero-posterior diameters. There are three antero-posterior diameters of the pelvic inlet called as diagonal conjugate, the second one being true conjugate, and the third being obstetric conjugate. Out of these three, the most important for us is diagonal conjugate. The reason being, out of the three AP diameters, this is the only antero-posterior diameter which can be measured. So diagonal conjugate is the only AP diameter that can be measured, and it is 12 centimeters. The diagonal conjugate is the distance from the inferior border of symphysis pubis to sacral promontory. So inferior border of symphysis pubis to sacral promontory, measuring 12 centimeters. The obstetric conjugate is the shortest of these three, and it is from the inner side of symphysis pubis to the sacral promontory. The obstetric conjugate is obtained by subtracting 1.5 centimeters from the diagonal. So it is diagonal conjugate minus 1.5, and it is 10.5 centimeters. The diagonal conjugate measures 10.5 centimeters. Finally, the true conjugate, which is from the upper inner border of symphysis pubis to sacral promontory. The true conjugate measures 11 centimeters. The true conjugate measures 11 centimeters. If you talk about the cavity, then the most important diameter in the cavity for us becomes interspinous diameter. So it is the interspinous diameter, that is the distance between the two ischial spines, and the distance between the two ischial spines is 10.5 centimeters. It is 10.5 centimeters. Within the outlet, the diameter important for us is intertuberous, that is the distance between the two ischial tuberosities. This measures 11 centimeters. This measures 11 centimeters, or the intertuberous diameter. Now, once we know these diameters of the female pelvis and the fetus, we can talk about the steps of normal labor. The first being, we said, is engagement. The first step of normal labor is engagement. Engagement is followed by two continuous movements. One is called as descent and the other is flexion. So one is descent and the other is flexion. Till the point it reaches the level of ischial spines. Once the head reaches the level of the ischial spines, there is going to be internal rotation. So we must know internal rotation takes place at what levels? It takes place at the level of ischial spines. And the ischial spines are regarded as zero station. Now what is exactly this station? See, the pelvis, if this is what I presume to be the pelvis, and this is where the ischial spines are. So I am saying that the ischial spines are taken as zero station. Above and below the ischial spine, we divide the spines into the pelvis into -1, -2, -3, -4 and so on. -5. Similarly, below the ischial spine, we say +1, +2, +3, +4, +5. Now, what are these -1, -2 and +1, +2? The numerical describes centimeters above and below the ischial spine. So, when we say -1, it means 1 centimeter above ischial spine. When we say +1, it means 1 centimeter below ischial spine. So this is how we describe the station of the head on parvaginum examination. So we are saying that internal rotation occurs at the level of ischial spines, which are described as zero station. After internal rotation, there will be crowning, which we don't write separately, and then there is delivery of head. And the important point to remember here is that the delivery of head in normal labor occurs by extension. The movement which is responsible for the delivery of the head in normal labor is extension. Finally, there is going to be external rotation. And once you say external rotation, is what you see or what the obstetrician sees outside is the movement of the fetal head. Inside, correspondingly, there is going to be a movement of the shoulders, which is called as restitution. But externally, we can only see external rotation. And finally, delivery of rest of the body by lateral flexion. Delivery of rest of the body by lateral flexion. Now please understand, when we say normal labor, it has to be vertex presentation. Alright, so when you say normal labor, it is vertex presentation. The vertex, if you talk about the vertex, and if we presume or we take a cut section and we say this is what the female pelvis is like, the female pelvis is divided into 8 positions. This is the left side, this is the right side. This position will be called as transverse. The anterior positions are called as anterior, and these would be called as posterior positions. So therefore, the head can be present anywhere in these 8 positions. But the most common position is LOT. When you say LOT, it means left occipito-transverse, which means that the occiput of the baby or the head of the baby is present towards the left maternal thigh in the transverse position. So when you say left occipito-transverse, this would be the position of the head of the vertex. Similarly, if it is present here, it will be called as, if it is present anywhere anterior to it, it will be called as LOA. Okay? So I'm saying the most common presentation is or position of the head is left occipito-transverse, and it is not LOA. Only when labor proceeds, this LOT gets converted into LOA. So initially, the most common presentation or position of the fetal head is LOT. Alright. Now, once we know little basics about what normal is, we'll go into more details of the same things now. Dystocia, which means nothing but slow labor or abnormal labor. Now, since you say dystocia is slow labor or abnormal labor, for the labor to proceed normally, 3 things have to be present in normal conditions. What are those 3 things? The 3 things are the passage. The second thing is the passenger. And the third thing is push. By passage, we mean the pelvis. By passenger, we mean the fetus. And by push, we mean uterine contractions. So all these three things, the pelvis, the fetus and the contractions, have to be present in a coordinated manner for the labor to be normal. If any of these three deviates, the labor goes from normal to abnormal or technically called as dystocia. So we take it one by one, that what things would make it as dystocia. And the first thing we talk about is pelvis. Now the maternal pelvis is divided into 4 types. The 4 types of pelvis are gynecoid, anthropoid, android, and platypeloid. So the 4 types of pelvis are gynecoid, anthropoid, android, and platypeloid. I have written them in a particular order because it is important. So the most common is gynecoid, seen in 50% of females, followed by anthropoid, seen in 25% of females, followed by android, seen in 20% of females, and platypeloid, which is seen in only 5%, and it is the least common type of pelvis found in the females. Now, as you all know that the pelvis is not present absolutely horizontal in the body. It has an angle of inclination. Now, this is the angle which the pelvis makes with the horizontal. The angle of inclination of the pelvis is 55 degrees. The angle of inclination of the pelvis is 55 degrees. Now, the gynecoid is the normal pelvis, and if it deviates from the gynecoid and becomes an android or an anthropoid, there appears a problem. Now, there are certain differences between gynecoid and android pelvis, which we must know. The gynecoid is the typical female pelvis and an android is a typical male pelvis. Now, when you talk about a gynecoid pelvis, the inlet of the gynecoid pelvis is circular. Basically, this division of the pelvis into gynecoid, anthropoid, android, and platypeloid is on the basis of shape of the inlet. So, how do we divide the pelvis into 4 types? On the basis of shape of the inlet. So, in the gynecoid pelvis, the inlet is circular in shape. In the android pelvis, it is heart-shaped. So, the inlet is heart-shaped. When you talk about the gynecoid pelvis, the side walls we say are parallel, whereas in an android pelvis, the side walls are convergent. The ischial spines in a gynecoid pelvis are blunt and not prominent, whereas in an android pelvis, the ischial spines are sharp and prominent. The subpubic angle is obtuse in a gynecoid pelvis, whereas the subpubic angle is acute in an android pelvis. A gynecoid pelvis is a shallow pelvis. So, if you basically see the distance from the inlet to the outlet, it is not much, it is a small distance. Whereas an android pelvis is a deep pelvis. So, the distance between the inlet and the outlet is quite big. So, the distance which the baby has to travel also increases simply because this kind of a pelvis is a deep pelvis. Now, with regards to abnormalities in the pelvis, there are certain terminologies again. One is a rachitic pelvis. So, a rachitic pelvis is one which has been affected by rickets. Triradiate pelvis is seen in vitamin D deficiency. Naegeli's pelvis is called when one ala of sacrum is missing and Robert's pelvis when both alae of sacrum are missing. Please remember that Naegeli's and Robert's pelvis are absolute contraindications for vaginal delivery. They are absolute contraindications for vaginal delivery. The only mode of delivery in a Naegeli's and a Robert's pelvis is a cesarean section. Now, also when you talk about pelvis, there are two more terms that we need to know. One is called as CPD, which stands for cephalopelvic disproportion, and the other term is a contracted pelvis. Now, please understand that these two are different from each other. Cephalopelvic disproportion is never permanent. It will change from one pregnancy to another because it is the relative difference in the size of the pelvis and the fetal skull. Whereas a contracted pelvis is a permanent fixture which will not change from one pregnancy to another. A contracted pelvis which is contracted in first pregnancy will remain contracted in the second pregnancy, and it will remain contracted in the third pregnancy as well. Now, you may be asked, what is the best method to know whether there is any CPD or not? So, what is the best method to know if cephalopelvic disproportion is present or it is not present? The best method to know CPD is trial of labor. That is, you allow the woman to go into labor. If the head does not get stuck, then there is no CPD. If it gets stuck, there is CPD. So, this is the best way to know whether there is cephalopelvic disproportion or not. But we can't rely every time on Bhagwan or God that let us see what happens, let us leave the patient on to deliver and let's see if it gets stuck. So, we as doctors have something that we can do beforehand as well. So, what we do is called as a pelvic assessment. The pelvic assessment is something which obstetricians do in order to rule out any gross deformity in the pelvis or gross abnormality in the pelvis. Now, please understand that pelvic assessment is done in primi gravidas at 37 weeks of POG, because beyond this time they can go any time in labor. So, we have to assess their pelvis before they go into labor to see whether there is any gross deformity in the pelvis present or not. Whereas in multigravida, since they have already had the process of labor before, it is almost sure that there is not going to be any gross derangement in the pelvis. So, in multigravida, the pelvic assessment is done at the onset of labor. All right. Then we come to the second term that I said, contracted pelvis. Now we have certain criteria before we can call the pelvis as contracted. So the pelvis can be contracted at the level of inlet, it may be contracted at the level of outlet, or it may be contracted at the level of cavity. So we have different criteria for all three. So if it is inlet, the criteria to call the pelvis as contracted is when the shortest AP diameter is less than 10 centimeters. And what was the shortest AP diameter among in the inlet? It was obstetric conjugate. Yes? So when the shortest AP diameter is less than 10 centimeters, it is called as a contracted inlet. But there is a possibility when the question does not mention about the shortest AP, it can be given in the form of diagonal conjugate. So at what value of diagonal conjugate will you call the pelvis contracted? The answer is 11.5, because the obstetric conjugate was 1.5 centimeters shorter than the diagonal conjugate. So therefore the cutoff we use to call the inlet as contracted with diagonal conjugate is 11.5, and otherwise the cutoff for the shortest AP diameter is 10 centimeters. For mid pelvis or the cavity, we say it is contracted when the interspinous diameter is less than 8 centimeters. When the interspinous diameter is less than 8 centimeters. Similarly, for the outlet, we say that it is contracted when the intertuberous diameter is again less than 8 centimeters. So the cutoff for the outlet is 8, the cutoff for the cavity is 8, and the cutoff for the inlet is going to be 10 centimeters. So these are the cutoffs to call the pelvis as a contracted pelvis. Alright. And please remember, contracted pelvis is an absolute indication to do cesarean section. Okay, it is an absolute indication to do cesarean section, and it is a recurrent indication, because I just told you a few minutes back that a contracted pelvis will always remain contracted even if the fetus goes on changing. So therefore, once the pelvis is described as contracted, it is taken so for subsequent pregnancies as well, and the patient will have to undergo repeated cesarean sections. Whereas CPD is never a recurrent indication. CPD is never or is not a recurrent indication for cesarean section, because the fetus keeps changing with every pregnancy. So if the first baby was bigger, there is possibility that the second baby is going to be a little smaller in size, and then the pelvis would be roomy for the same baby, right? So CPD is not recurrent, whereas contracted pelvis is a recurrent condition. The second thing we talk about is push. So we don't talk about the passenger right now. We talk about push, and as I said that by push we mean uterine contractions. So uterus is something which during labor keeps contracting, right? And just like the heart, which has to keep contracting, it has a pacemaker. The uterine contractions or the uterus also has a pacemaker. The pacemaker of the uterus is at the cornu. The pacemaker of the uterus is at the cornu, and the contractions are going to spread from the cornu. The contractions are going to spread from the cornu, and they spread at the rate of 2 centimeters per second. The contractions spread from the cornu at the rate of 2 centimeters per second, and they depolarize the entire organ in 15 seconds. They depolarize the entire organ in 15 seconds. Now, when you talk about uterine contractions, the uterine contractions, or when the uterus contracts, it is going to generate some intrauterine pressure, right? It is going to generate some intrauterine pressure, and therefore we have various numerical questions on it. So the first question goes like, at what intrauterine pressure are the contractions palpable? So they are palpable when they generate a pressure of 10 millimeters of mercury. The next question is, at what intrauterine pressure are the contractions painful? The contractions are painful at a pressure of 15 millimeters of mercury. What is the minimum pressure or intrauterine pressure which is required for cervical dilatation? The minimum pressure which is required for cervical dilatation is again 15 millimeters of mercury. So they are palpable at 10 mmHg, painful at 15 mmHg. The pressure required to dilate the cervix is again 15 mmHg. And then at what intrauterine pressure the fundus of uterus cannot be indented? So that means when you try and press the fundus, it will not get depressed. The answer is 40 millimeters of mercury. The answer is 40 millimeters of mercury. The next thing about uterine contractions is, how do you define adequate contraction? How do you define adequate contractions? So there are two criteria to call a contraction adequate. The first being, there should be 3 contractions in 20 minutes. 3 contractions, in 10 minutes, not 20 minutes. 3 contractions in 10 minutes, each lasting for 45 seconds. So one contraction should last for 45 seconds, and there should be 3 such contractions in a span of 10 minutes. That is the first criteria. The second criteria is that the contractions generate a pressure of 200 to 220 Montevideo units. 200 to 220 Montevideo units. Now you have to understand what is this new term that I have said as Montevideo units. The Montevideo units are calculated as follows. So they are number of contractions in 10 minutes, number of contractions in 10 minutes multiplied by the pressure generated by each contraction, multiplied by the pressure generated by each contraction. So what Montevideo units are required for onset of labor? 80 to 120 Montevideo units. So for onset of clinical labor, the Montevideo units are 80 to 120 Montevideo units, whereas 200 to 220 Montevideo units are the maximum pressure, or is the maximum pressure that can be generated in the uterine contractions, and it is considered adequate for expulsion of the fetus. So 200 to 220 Montevideo units is the pressure which will be generated in the second stage of labor, and it is good enough to expel the fetus. So clinical labor begins at 80 to 120 Montevideo units, whereas the maximum pressure that the uterine contractions can generate is 200 to 220 Montevideo units. Now there is also a condition called as hyperstimulation. Alright, so how do we define hyperstimulation? So hyperstimulation is defined as more than 5 contractions in 10 minutes, which means that the contractions are coming at less than 2-minute interval. Now the problem with such type of contractions is that they significantly reduce the uteroplacental blood flow. They significantly reduce the uteroplacental blood flow, and since they reduce the uteroplacental blood flow, they will result in fetal distress. So hyperstimulated uterus or hyperstimulation contractions produce fetal distress. Usually this kind of a condition is produced with labors which are being augmented with oxytocin. So when you give oxytocin to augment the process of labor, the patient may develop a hyperstimulation syndrome or a hyperstimulated uterus. Now what is the management of hyperstimulation? The first thing to be done is stop the oxytocin drip which is running. So stop oxytocin. Yes, Jammu, I will listen to you. I assure you that listen to what is being taught right now. Yes, whatever your problem is, I'll take it up at the end of the class. There's no issue. Alright, so relax and listen to what I'm speaking right now. Otherwise, you will keep missing ahead. Right? So, oxytocin augmented. If there is hyperstimulation, what do? The first thing to be done is stop oxytocin. Make the patient lie in left lateral position. Make the patient lie in left lateral position. Give her oxygen by the mask. Start IV fluids. And if required, we can even give tocolytics. Tocolytics are drugs which reduce the uterine contractions. Now this is very important because if you don't do this, that means if the uterus is not relaxing in between the contractions, it will not give good blood supply to the baby. The baby will develop fetal distress and it will die. So therefore, this is how we manage a case of hyperstimulation, especially seen with augmented labors. Right? So this was about uterine contractions. Now what we talk about is the passenger, right? You want a break right now? Why not finish the class only and then straight away go home? Right? No point taking a break right now. So what you talk about is the passenger now. I will take the class only if you let me finish the class. Right? So just let me carry on. I will finish when I have to. Don't bother. Listen, sit, try and listen as much as you can. Take down the notes very, very properly. It is going to be the most important thing for you. Alright? So when you talk about, I think I'm going to take till 9 o'clock. That is the determined time, and I'm not going to leave you before that. So it's going to be till 9, right? Okay, so when you talk about the passenger, which means the baby. So I said so by passenger we mean the baby, and I said whenever the baby is in vertex it is normal, and whenever the baby is in any other presentation it is going to be abnormal. So what we talk about in the passenger is going to be malpresentations. Okay, it is going to be malpresentations. The first thing what we talk about is occipito-posterior. Alright, the first thing we talk about is occipito-posterior. And the most important thing about occipito-posterior is, if you can answer my question, what is the presentation when it is occipito-posterior? When the head is in occipito-posterior, what is the presentation? Anybody? Anybody can answer that? If the head of the baby is in occipito-posterior, what is the presentation? No. What is the presentation? It is still vertex presentation. So occipito-posterior, it is only a malposition. That is the first and the most important thing about OP. OP is a malposition. It is not a malpresentation. The presentation is still vertex, but instead of the anterior positions, OP is or the head is or the vertex is present in the posterior positions, and therefore it is called as a malposition. What is the most important cause or most common cause, whatever you want to call it as, of occipito-posterior position? The answer is android pelvis. The most common cause of occipito-posterior position is an android pelvis. Now I said that the most common position is LOT, right? So 40% of babies are present in LOT. Now we talk about how many percentage of babies are present in occipito-posterior. So our question is, just give me a moment please. How many percentage of babies are present in occipito-posterior position at the onset of labor? So at the onset of labor, 15 to 20% of babies are present in occipito-posterior position, out of this 15 to 20%, how many will be present at the end of labor? How many will be still in occipito-posterior? And the answer is only 5%. So out of 15 to 20%, most of these occipito-posterior, as labor progresses, converts into occipito-anterior, and only 5% will still remain in the occipito-posterior position. Okay? Then what we should know is, among occipito-posterior, what is the most common? So, in occipito-posterior, the most common is right occipito-posterior. So, in occipito-posterior, the most common is right occipito-posterior. What are the risk factors other than the type of pelvis? This is the only condition or malposition which is more commonly seen in nulliparous women, whereas all other malpresentations that we talk about, are more common in multiparous women, whereas occipito-posterior is more common in nulliparous women. What else is a risk factor? Obesity is a risk factor for occipito-posterior. Increased birth weight of the baby is also a risk factor for occipito-posterior position. The other pelvis which is also associated with occipito-posterior is called as anthropoid. So the most common is android, but anthropoid pelvis will also present or can have occipito-posterior, and we say persistent occipito-posterior and direct occipito-posterior. Persistent or direct occipito-posterior are both more common in anthropoid type of pelvis. They are more common in anthropoid type of pelvis. Now, let's look at what all could be the possibilities with an occipito-posterior baby. So let's say this is where the baby is present at the onset. Now, if everything is good, by which we mean if the pelvis is roomy, the baby is average size, and the contractions are good. So if these three things are good, then this occiput posterior rotates and comes anteriorly, and it converts into occipito anterior, and then delivery will take place just like it was occurring in occipito anterior. So the only problem in this case is going to be prolonged labor. So it is going to be a slow progress in the labor, but it will keep progressing. The baby is finally converted into OA position and it will deliver as an OA baby. But what if any one of these three things gets deranged? So either the pelvis is not that roomy, or the contractions are not very good, or the baby is slightly heavier, then what all could happen? Next possibility is, so the baby was originally here, the baby starts rotating, but because of abnormality in any of the three conditions, it gets arrested in the transverse position. This is called as deep transverse arrest. So the second outcome that is possible with occipito-posterior is deep transverse arrest. Now deep transverse arrest is seen in both android and anthropoid pelvis. But if you have to choose that it is more common in which one, then it is more common in android as compared to anthropoid. Okay, so it is more common in android as compared to anthropoid, right? So if you have to choose deep transverse arrest किस में ज़्यादा common है, then android is an answer as compared to anthropoid. What could be the third outcome? Okay, before I go to the outcome, what is the management of DTA? Now DTA in modern day obstetrics is managed only by a cesarean section. So in modern day obstetrics, what do we do, or what is the best possible thing for deep transverse arrest? It is a cesarean section. Although some people say, or in earlier days what was done was, the obstetrician used to take her hand inside and manually rotate the baby into anterior position. So this was called as manual rotation. And after manually rotating it, the head was delivered with forceps. So this was called as manual rotation with forceps extraction. So this is what was done previously. We don't do it any longer. Alright, so we are saying in DTA, in modern day obstetrics, what we are doing is a cesarean section. Although earlier on, what was done was manual rotation with forceps extraction. What does that mean? The obstetrician takes the hand inside per vaginum, manually rotates the baby into the anterior position, and once the baby is rotated, we deliver the baby with forceps. Another possibility was forceps rotation and forceps extraction. Now this is that we use the forceps to rotate the baby and then use a different forceps to extract the baby. Again, we are not doing these things now, but you should know that they are a possibility in deep transverse arrest. What we do, or what is the best thing to be done, is a cesarean section. Coming to what could be the third possibility, that this is where the head is present, occipito-posterior. Instead of rotating out anteriorly, it rotates posteriorly. It rotates posteriorly. Now this is called as persistent OP or a direct OP. Why direct? Because the occiput directly lies against sacral promontory. Therefore, it is called as direct occipito-posterior. Now, if we all realize and try and touch our occiput, what lies opposite to the occiput? Our face, right? So, if the occiput is towards sacral promontory, what lies against symphysis pubis? It is the face. That is why the mode of delivery in this case is called as face to pubes. It is called as face to pubes. So you will also be asked, in what kind of pelvis does face to pubes delivery occur? Again, the answer is anthropoid. So face to pubes delivery is seen in anthropoid pelvis. Now again, by what movement is the head delivered in a face to pubes delivery? Then again, The answer is extension. Only the initial movement is of flexion. Only the initial movement is of flexion, but finally the head is going to be delivered by extension only. So even in face to pubes delivery, the delivery of the head is by extension. Another problem with face to pubes delivery is that this is not a completely flexed head. It is a deflexed head. So in occipito-posterior positions, the head may not be completely flexed, it would rather be deflexed. When you say the head is deflexed, the engaging diameter changes from suboccipitobregmatic to either occipitobregmatic or it changes to occipitofrontal. Both these diameters, whether you say occipitobregmatic or you say occipitofrontal, are larger than suboccipitobregmatic. So suboccipitobregmatic was 9.5, occipitobregmatic is 10.5 and occipitofrontal is 11. Now why I am telling you this is because the space available in the vagina of the female is same. But what is happening now is that a bigger diameter is trying to come out. Yes? So when a bigger diameter tries to come out from the same space, what is going to happen? More injuries. So that is why face to pubes delivery is more associated with perineal injuries in the mother. So there are more perineal tears in the mother. So that means the incidence of third and fourth degree tears is more in occipito-posterior delivery as compared to an occipito-anterior delivery. Alright. So third and fourth degree tears, which are more severe form of perineal tears, are more common in occipito-posterior as compared to occipito-anterior. Alright. Then what we talk about the second malpresentation is going to be face presentation. Okay. Okay. So a few questions we have discussed about face presentation. The first being, what would be the engaging diameter? We said it is going to be submentobregmatic and it measured 9.5. Submentobregmatic and it measured 9.5 centimeters. What is the most common cause of face presentation? The answer is anencephaly. The most common cause of face presentation is anencephaly. Then what could be the other causes? So when you talk about the other causes which result in face presentation, the first thing they would want to ask you is, what type of pelvis favors face presentation? Right? So we say it is a platypeloid pelvis. It is a platypeloid pelvis which favors face presentation. Alright. Then any kind of, what was, if you remember the face presentation, the neck we said is completely extended. Right? We said the neck in this case is completely extended. So what you have to understand is, anything which does not allow flexion of the head, right? Anything which does not allow flexion of the head would result in face presentation. So anything which does not allow flexion of the head will result in face presentation. For example, if I want to enumerate what is the cause of face presentation, then any kind of an anterior neck mass. So for example, a big swelling in the neck of the baby will not allow flexion. The head will go into extension and it will lead to a face presentation. Similarly, presence of multiple nuchal loops. What are nuchal loops? Cord loop. So if there are multiple cord loops around the neck, they will again not allow flexion and it will result in extension and face presentation. Prematurity is again associated with face presentation. Polyhydramnios is associated with face presentation. And as I said, multiparity is going to be common to any malpresentation. So multiparity is a cause of any malpresentation that we talk about. Now, whenever you say face presentation, then you have to understand that among face presentation, the mentum of the baby can either be present anteriorly or it can be present posteriorly, just like the vertex. Like we talked about occipito-anterior and we talked about occipito-posterior. Similarly, in face presentation, the mentum can be mento-anterior or it can be mento-posterior, right? Now, why are we telling you this? Because when the baby is present in mento-anterior condition, then the delivery is possible by vaginal route. Whereas, if the baby is present in mento-posterior, vaginal delivery is not possible and the only mode of delivery is going to be a cesarean section. The only mode of delivery is going to be a cesarean section. Now, the question can be made a little more tough by adding one word before mento-posterior. So, if the question says the patient is in early labor and mento-posterior, what will you do? Or if the question says she is in advanced labor and mento-posterior, what do we do? The answer for both the questions are different. Now, when the patient is in early labor and she is mento-posterior, what we do is wait and watch. The reason, just like the majority of occipito-posterior were rotating into anterior, most of or almost 50% of mento-posterior would rotate into mento-anterior and there would be no need to do a C-section. Whereas, if the patient is in advanced labor and she is in mento-posterior, by which we mean, or another way how we can write the same thing is, persistent mento-posterior. Persistent mento-posterior, then again it means mento-posterior in advanced labor. Now here the answer would remain as cesarean section, because there was time for the head or for the mentum to rotate, but it did not rotate, and since it is a persistent mento-posterior or a mento-posterior in advanced labor, we are not going to wait any longer. Now we are going to take her up for a cesarean section because vaginal delivery is not possible. Alright. The next thing we talk about is a very similar presentation to face, and that is a brow presentation. Now we said that the baby is going to be in brow when there is partial extension. The engaging diameter we said was mento-vertical, which is 14 centimeters. So mento-vertical and 14 centimeters. The causes of brow presentation are exactly similar to those of face. Right? So the causes of brow are exactly similar to that of face presentation. But the problem with brow presentation is that this diameter, which is 14 centimeters, is just too big and it cannot come out from the vagina. Therefore, the only way to manage a brow presentation is a cesarean section. Alright? The only way to manage a brow presentation is going to be a cesarean section. Then we talk about transverse lie. Now, transverse lie, we said, is also called as shoulder presentation. And on per vaginum examination, if the baby is present in a transverse lie and I do a PV examination, what am I going to feel? I am going to feel the rib cage of the baby. And this particular feel on PV examination is called as a gridiron feel. It is called as a gridiron feel. So you should understand that in your AIPG exams, anything that has been given any name has a very high probability of being asked. So that is why telling you, if it says gridiron feel, it is used for a baby who is present in transverse lie. The most common cause of transverse lie is prematurity. The most common cause of transverse lie is prematurity. But they can twist the same question and ask it to you in a different way. What will they ask you? They will ask you, the most common cause of transverse lie in a term baby. So now they have already mentioned that the baby is term, so prematurity cannot be the answer, right? So what is the answer? It is placenta previa. So addition of only one statement or one word changes our answers at so many places, right? So if it says most common cause of transverse lie in a term baby, then the answer is placenta previa. The other risk factors for transverse lie are a platypeloid pelvis, as we said, multiparity, it is again a risk factor. Polyhydramnios would again be a risk factor. So these are among the other causes of transverse lie. Now, if you look at transverse lie, it is just not possible to deliver this baby from a small pelvis, right? So therefore, the management of transverse lie is cesarean section. But again, it is not as simple as this. There would be certain things written which would change your answers. Now, for example, I say that a primigravida comes at 37 weeks with transverse lie. What should be your next step? So I'm saying a primary gravida presents to us at 37 weeks with transverse lie. What should be our next step? Now the answer here is not a cesarean section. What is the answer? The answer here is a procedure called as ECV. It stands for external cephalic version. ECV or external cephalic version. What are the prerequisites? What are the prerequisites to do ECV? The prerequisites to do ECV are: number 1, the patient should be beyond 36 weeks of POG. The patient's period of gestation should be more than 36 weeks. Secondly, liquor should be adequate. So we cannot do ECV if the mother has oligohydramnios. So the liquor should be adequate. The third requirement is the membranes should be intact. With ruptured membranes, external cephalic version is a contraindication. So ECV is a contraindication with ruptured membranes. Fourth, the patient should be in early labor. At the max, should be in early labor. Now what do we mean by early labor? In latent phase. We cannot do ECV if the patient is in active phase of labor. So we can't do an external cephalic version if the patient is in active phase of labor. The fifth point is just to complete the list, and that is there should be no contraindication. There should be no contraindication for vaginal delivery. It is logical. If there is any contraindication for vaginal delivery, what will you do after rotating the baby? You cannot still do a vaginal delivery. So if there is any contraindication for vaginal delivery, there is no need to go do an ECV. You straight away take the patient up for a CS, right? So anytime when these criteria are met and the patient is in non-vertex presentation, then what we first try is ECV. All right. Other situations with transverse lie where they try and confuse you. Transverse lie with an IUD baby. The baby is dead in utero. Alright, the baby has died in utero. How do you deliver this baby now? The answer remains a cesarean section. So in fact, transverse lie is one of the indications where we do a CS even for an IUD baby. So where we do a cesarean section even for an IUD baby. Now what happens in transverse lie is that sometimes the patients are coming from far areas to a tertiary care hospital. By the time they reach your hospital, the cervix is already dilated because of the contractions, but the delivery is not possible. Now what happens is, from this dilated cervix, one hand of the baby falls out, and then the cervix keeps contracting against this hand of the baby or the arm of the baby. This is called as neglected shoulder. Neglected shoulder also actually eventually results in an IUD baby. And when this question comes like that, a transverse lie with neglected shoulder with IUD baby, what do? The answer is CS. Alright, the answer is a cesarean section. With a neglected or an impacted shoulder, you cannot try external cephalic version. Alright, you will have to do a cesarean section in this case. Now when you talk about transverse lie, there is just one condition. There is just one condition where vaginal delivery is possible. And that is called as corpora conduplicata. It is called as corpora conduplicata. It is a rare scenario where vaginal delivery is possible even with transverse lie. How is it possible? Now this is seen in old intrauterine dead babies who are also premature. So old preterm IUD babies can deliver, when present in a transverse lie, can deliver vaginally by a process called as corpora conduplicata. Now if you talk about corpora conduplicata, it means delivery in double up fashion. So this is how the baby is present in transverse lie. It undergoes, or it folds on itself, it gets folded, so it gets doubled up, and then it reduces its diameters and can come out of the pelvis. So this is called as delivery in a double up fashion. The technical term is corpora conduplicata, a rare situation where vaginal delivery is possible even in transverse lie. Especially it is seen when the baby is an old preterm IUD baby. Why? Because preterm it will be small. IUD, what happens? The baby undergoes maceration. It loses all its tone and it can easily get folded on itself. So that is why it is seen with old preterm IUD babies, corpora conduplicata. Right? We talk about the last presentation for the today, and that's going to be a breech. All right. Now we talk about the breech presentation. Please remember that even with breech presentation, the lie was longitudinal. Right? The lie was longitudinal in breech presentation. The most common cause of breech presentation is prematurity. The most common cause of breech presentation is prematurity. The incidence of breech at term, is 3%. Incidence of breech at term is 3%. There are 3 types of breech. A flexed breech, also called as a complete breech. So a flexed breech, also called as a complete breech. Second is a frank breech. And third is footling. Which out of the 3 is the most common type of breech? The most common type of breech is frank breech. Now sometimes they try and further confuse you. How? Usually this question comes as it is. What is the most common type of breech? And the answer is frank. But now they can also confuse you saying, what is the most common type of breech in primigravida? And what is the most common type of breech in multigravida? So in primigravida, the most common type of breech is frank, whereas in multigravida, the most common type of breech is a flexed breech. Right? Which type of breech? Which type of breech has highest risk of cord prolapse? Which type of breech has highest risk of cord prolapse? The answer is footling. And minimum risk of cord prolapse the minimum risk of cord prolapse is seen with frank breech. So highest incidence or risk is with footling breech, and the minimum risk is with frank breech. Now the problem is, sometimes, as I said, we get overconfident with the questions. Now this question can very well be framed as, which of the following has highest risk of cord prolapse? The first would be footling, second option would be frank, third option being transverse lie. Now our problem is, the moment we see highest risk of cord prolapse and footling as the first option, there we go. And we don't even look at the options below. The highest incidence of cord prolapse per se is with transverse lie. Yes, the answer is 3. The highest incidence of cord prolapse is with transverse lie, followed by footling breech. So again, you have to be very careful and not be overconfident with the answers, right? So read the question carefully and read the options carefully as well. So if it says like this, then what we choose the answer to be is transverse lie and not footling breech. Now when you talk about breech presentation, as an obstetrician, my primary concern is, do I deliver this baby by a cesarean section, or do I deliver this baby by a vaginal route? Right? That is my prime concern. How am I going to deliver this baby? So now we're going to write a table where we are going to write indications for cesarean section. Right? What are the indications for cesarean section in breech presentation? The first indication is easy for you to understand. The answer is, or the first answer is footling. Simply because if you leave them for vaginal delivery, the cord will fall out and the baby will die. Right? So since the risk of cord prolapse is very high, we don't leave them for vaginal delivery, we take them up for a CS. The second condition is when the baby is breech but the neck is hyperextended. Alright, so when the baby is breech and the neck is hyperextended. Now there is a special name given to this, asked in recent AIPG exam. So what is the name given to this condition? This is called as a stargazer baby. Why? Because it looks as if the baby is looking at the stars. It is called as a stargazer baby. Now what is the problem with hyperextended neck? That we can't leave it for a vaginal delivery, because when the neck is hyperextended, what will happen? The baby, the buttocks and the trunk are going to come out, but the aftercoming head of the baby is going to get stuck. Now once the aftercoming head gets stuck, there is hypoxic injury to the brain, and in more severe cases it can even lead to death of the baby, right? So third indication where we do a cesarean section is a preterm breech. There is higher risk of head getting stuck with a preterm baby, and a preterm baby can tolerate hypoxia, cannot tolerate hypoxia as well as a term baby. So the brain injury is going to be much more for a preterm baby if the head gets stuck. So for preterm babies, again, we do a cesarean section. Primigravida. Now for all practical purposes, any patient who is a primigravida and who has a breech presentation, we deliver her by a cesarean section. Although it is only a relative indication. Now why do I say that? Because as per the ACOG guidelines, that is the American College of Obstetricians and Gynecologists, and the guidelines say that the mother can be explained the risks. For example, she can be told, look, that your baby is present in a breech presentation, and there is a possibility that the aftercoming head will get stuck. Then either the baby will be suffering from cerebral palsy, or in more severe cases, the baby will die. And then you ask her, what do you want? So obviously, what is she going to say? She's going to say, please deliver by cesarean section. But the guideline says that after knowing the risk, if the mother says, no, I am ready to take the risk, I want to undergo vaginal delivery, then she can be allowed vaginal delivery. So that is why we say primi gravida is a relative indication, although for all practical purposes, everywhere, whether you talk of government hospitals, private hospitals, wherever you talk, everybody does a cesarean section because nobody is willing to take that risk of head stuck, right? Similarly, another thing which is practically taken as an absolute indication but is a relative indication is the patient is previous cesarean and her current baby is in breech presentation. So now we are adding one more risk. Yes, the risk of head stuck is there, and additional risk we are adding is rupture uterus, right? So जब हम प्राइमी ग्रेविडा का ही सिजेरियन करते हैं, so previous cesarean with breech को तो हम definitely cesarean कर देते हैं, right? But again, as per the guidelines, it is only relative, because again it says the same thing, that if the mother is willing to take the risk, then you can allow vaginal delivery for her. Finally, what else is indication for cesarean section? If the fetus is suffering from macrosomia, so if it is a big sized baby, the probability that the head of the baby is going to get stuck is also higher, right? So we don't leave this baby for a vaginal delivery, we take the baby up for a CS. Last point is a baby who suffers from hydrocephalus. So if a baby has hydrocephalus, then we deliver this baby by cesarean section, and post delivery the pediatric surgeons do a procedure on them which is called as ventriculoperitoneal shunts. The ventriculoperitoneal shunts have very good outcomes, and therefore we deliver these babies by a CS. But on the other hand, if there is hydrocephalus and along with that the baby has multiple other anomalies, right? By which we mean that this baby is incompatible with life. So बच्चे में इतनी सारी खराबियां हैं but the baby is incompatible with life, then you don't do a cesarean section. So when it is written specifically like this, that there is hydrocephalus and the baby is grossly malformed, then we allow vaginal delivery. So everything is going to come out. The buttocks will be delivered, the trunk will be delivered, but the aftercoming head is going to get stuck. Once the aftercoming head comes down, what we do is called as cephalocentesis, which is we put a needle into the suture line of the baby's head and connect the needle to a catheter. What will it do? It will start draining the CSF. Once the majority of CSF is drained out, what will happen? The skull bones are going to get collapsed, the diameters are going to reduce, and the head is going to come out, right? Now, but this is only reserved for babies who are incompatible with life, simply because once you allow the skull bones to collapse, whatever little brain matter is there inside, even that is going to be destroyed. So these babies would have no chance of survival after that. So when it is hydrocephalus and multiple anomalies, we do cephalocentesis, otherwise we do a cesarean section, right? Now another thing, similarly, how they may confuse you, it's a similar question. A primi gravida presents to you at 37 weeks with breech presentation. What do you do? What is the next step? The answer remains what we had said for a transverse lie. We will first try an external cephalic version, provided all the prerequisites for external cephalic version are met. We've already given you the criteria for requirement of ECV, and if those criteria are met, we would do external cephalic version, right? Otherwise, what will you do? A cesarean section. So, if those criteria are not met, then we do a cesarean section. If those criteria are met, so criteria not met, we take her up for a CS. Criteria met, we take her up for external cephalic version. Now, when you talk about breech presentation, there are certain maneuvers which are named maneuvers and which are asked in the exams. For example, the first maneuver we talk about is Lovset's maneuver. The Lovset's maneuver is used for the delivery of extended arms. It is used for the delivery of extended arms. Then Pinard's maneuver. Pinard's maneuver is used for the delivery of extended legs. What are the procedures used for delivery of after coming head? So for the delivery of after coming head, the most commonly used method is Burns-Marshall. The most commonly used method is Burns-Marshall. The second method which can be used for the delivery of after coming head is called as MSV. Morrisseau Smelly Wheat. Morrisseau Smelly Wheat. What do we do in this method? We do malar flexion and shoulder traction. So what we do is malar flexion, shoulder traction. The third method used for the delivery of after coming head is Piper's forceps. So this is a special forceps which is used for the delivery of after coming head called as the Piper's forceps. Then another named procedure is Prague's maneuver. The Prague's maneuver is used for delivery of the after coming head when the baby is in dorso-posterior position. What do we mean by dorso-posterior position? Normally, most of the breech are present in dorso-anterior, which means that the spine of the baby faces the obstetrician and the abdomen of the baby is towards the sacrum. So that is dorso-anterior. If the reverse happens, that is the spine is towards the sacrum and the abdomen is towards the obstetrician, it is called as a dorso-posterior breech. And then the method we use to deliver is called as Prague's maneuver, right? And then there is, if you talk about the maneuvers, there's a maneuver which is used for the delivery of preterm baby. Alright, for the delivery of preterm baby, once the head gets stuck, now what happens is, in a preterm baby, the buttocks and the trunk are going to come out, but the head will get stuck. Now when the head gets stuck, we have to hasten the process of delivery because I said that the preterm babies are more prone to hypoxic injury. So what we do in this case is we give incision on the cervix. We give incision on the cervix, and this incision is given at 2 o'clock and 10 o'clock position. This incision on the cervix is given at 2 o'clock and 10 o'clock position, and the name of the procedure is just slipped out of my mind. Maybe I'll just recall it in 2 minutes or so. But what it is done is that we give incision at 2 o'clock and 10 o'clock positions. That will open up the cervix and the head of the preterm baby comes out. So this is what we do if the head of the preterm baby gets stuck. Alright. Now till I recall the name, this is the session for today. Right. And now you can put up your doubts, and meanwhile I'll just give you the name of the procedure as well. Yes. So doubts from whatever places you want to ask. We'll take up your doubts now. Yes. There was a doubt from Shimla. Yes, tell me. What is your doubt? Ludhiana, your doubt is something that I'm going to take up last. They're asking me which book to study. Other than that, any other questions that you want me to answer? Or you're dead tired to even ask MCQs? Yes, all right, Shimla, thank you so much. So they've recalled the name for me. I'm glad. Yes, so it is called as, so thanks a ton, that happens sometimes, there's a blackout. So I said I'll give you the name of the incision, and it is called as Duherson's incision, right? All right, so the name of the incision that we give for delivery of the preterm baby's head is called as Duherson's incision, where I said the incision is given at 2 o'clock and 10 o'clock position on the cervix, right? All right, now let's take up the doubts. So one of the doubts is contents of the broad ligament, right? What do you want me to enumerate the contents again? All right, the contents of the broad ligament would be, we start from above, so they are the structures present in the broad ligament above. So I said there would be round ligament, fallopian tube, ovarian ligament. The other contents are ovaries and their ligaments, remnants of the Wolffian duct, which included epiphoron, paraphoron and Gartner's duct. Then they include connective tissue, blood vessels and nerves. So these are the contents of the broad ligament. Yes, then what else? What is the question? Stop. Let me read, guys. Please repeat. Oh, you want me to repeat the entire anatomy? They'll play that for you, right? See, Belgaum, I think you did not hear me correctly, right? I said when you are asking about the vaginal epithelium is derived from, we say the upper 2/3 is derived from the mesoderm of Mullerian duct, and the lower 1/3 is derived from the endoderm of urogenital sinus. And I am dead sure of that. This is in consensus with anatomy professor as well, right? So what else? Steps of labor. From internal rotation. Now what do you want? Internal rotation ke baad not much is left behind. Once internal rotation occurs, so what happens after internal rotation is that the occiput comes to lie under symphysis pubis. Okay, so what happens after internal rotation is the occiput lies under symphysis pubis. After this, the delivery of the head occurs by extension. Okay, so the delivery of the head occurs by extension. Now, once the head is delivered, after this there is going to be external rotation. Now, when we say there is external rotation, this means the occiput will come to lie in the original position from which it started inside the pelvis. So inside it was LOT, right? So occiput was facing the left maternal thigh. So even after external rotation, the occiput will face the left maternal thigh. And I said, when you are seeing external rotation from outside, what will happen inside? Inside, what is happening is restitution. Now, what is actually happening in restitution is that there is rotation of the shoulders. There is rotation of shoulders such that the anterior shoulder will come and lie under symphysis pubis. So this is what is happening inside the pelvis. Alright, then what else? What else? Answer our query. Allahabad ki query kya hai yaar? Allahabad, type your query again. I haven't read your query, so don't get angry with me. What are you writing? See, whatever you have missed, we'll play that for you. I can't repeat the entire topics all over again. If you have your queries, then ask me that. Most common position. I said it LOT. I won't change my answer just because you're asking again. I said it is LOT, and I'm quoting Williams obstetrics on that. Right? Types of placentas, see, usually it is. What I'm going to do is I'm going to give you an update on placentas or types if you want, because there is not much into it. I've given it once before as well. So you describe them as bilobata when there are two lobes, succenturiata when there is an extra lobe. So there is a placenta which is called as bilobata. So when there are two lobes of equal sizes, right? Then there is succenturiata, which means there is an small additional lobe. And what is the problem with this succenturiata placenta? That there is possibility of retained placenta. The small lobes gets left inside and it presents with postpartum hemorrhage, right? There is not much into it. There are certain standard things which you need to know. So I can even give you an update on that. What else? What else do you want me to tell you? Nerve supply of ovary. So I said the nerve supply of ovary is hypogastric plexus, alright. So it is the pelvic plexus or the hypogastric plexus, and along with that we said that the referred plane of the ovary travels along the obturator nerve. The referred plane of the ovary travels along the obturator nerve and is felt along the medial aspect of the thigh. Okay, it is felt along the medial aspect of the thigh. Allahabad. Upar move karna hai. I want to see what Allahabad is writing. Cutoff for nuchal translucency for Downs is more than 3.5 mm. Please see my updates. You should be. I'm very, very active on the Facebook club. I've recently again given an update on Downs, and all the updates are going to be very, very useful. So please see the latest updates. They were on Down syndrome, and I've given the various cutoffs there as well. For nuchal translucency, it is 3.5 mm. All right. Now, as far Ludhiana is asking, is ovary intraperitoneal or retroperitoneal? Now, Ludhiana, that is a very, very debatable question. Most books give different answers, but a better answer is intraperitoneal. That is what majority of books stick to. Alright. Although it is debatable, some say it is intraperitoneal, some say it is retroperitoneal, but a better answer of the two is intraperitoneal. Belgaum, I will teach you bishops. Why do you want to hurry into it? Right. So, pelvic assessment in multi. I told you pelvic assessment in multiparous women is done at the onset of labor, whereas pelvic assessment in primigravida is done at 37 weeks. Jabalpur, instead of writing, please tell me what you want to know. Yes, precisely. That is the reason I'm saying it is intraperitoneal. Had it not been intraperitoneal, there is never a possibility of an abdominal ectopic, which is, we are saying, always secondary, right? If it was extraperitoneal, then abdominal ectopic should never occur. Secondly, had it been extraperitoneal, then blood will never collect in pouch of Douglas. Whereas we say that in ectopic pregnancies, whether it is ovarian or whether it is fallopian tube, the blood, or there is collection of blood in the pouch of Douglas. So both these statements tell you that the thing is that it is intraperitoneal. That is why I said it is debatable, but the better answer is intraperitoneal. All right, then. Now, I told you the best method to assess CT scan, to assess cephalopelvic disproportion is trial of labor. Okay, it is trial of labor. If it is not in the options, then the best answer is MRI. CT scan is never an answer. The answer for this question, in case assessment, pelvic assessment is not there, is MRI. Followed by MRI, it is a bimanual examination. That is what we do. That is a pelvic examination that we do. Right? What else? Please advise on how to study. For obs and gynae, you rest assured that if you do my notes properly, 95% of questions would be from my notes. All right? I'm saying that. But provided you do them nicely, so you are not supposed to, filter my notes again. So whatever I'm giving you is required for your preparation. So you can't filter it further. Secondly, if you want to do MCQs, you should use a couple of books together. So please don't study the subject-wise guide of obs and gynae. It is hopeless and pathetic. There are wrong answers, wrong references. It is really, really bad. In case you want to do that book, just do the questions, don't study the answers, and don't study the references at all. If you have any doubt on any of the questions, you can put them on the club and tag them to me, and I assure you that I'll answer them. Right? Otherwise, a better way is to combine one All India book, one DNB book, one AIPG book, and do the obs and gynae questions from these books rather than doing a subject-wise guide. So do my notes and do one book of each type. Right? What else? What are you asking? First week slides of Bartholin. See, I don't remember what was the slide after that. So whatever you have missed in the notes, you let us know and we'll play it again for you. That is what we can do. All right. So is it a final good night from your side? Can I take your leave? Yes, is any doubt left? I'm still here, I'm sitting, and if you have any doubt, I'll clear them before going. Right? So, all right. Okay. So, very good night. We see you tomorrow, and the class starts at 11 o'clock tomorrow. All right? So, we'll start at 11, and it's going to be a good session again, a good long session. So, sleep well and come tomorrow. All right? Bye.